Well, good morning. We're delighted to see so many people out on a Saturday morning in Seattle. I know most of you are from the area. I know some are not. And I just want to give you a warm welcome to our participants and our speakers. We have some from out of town. We have patient stories. And as you saw, one of our patient storytellers is someone well known to this city. We'll be in kind of at the time of the story and then probably shortly after that gone because her schedule is very full. But we're delighted to have you here. And I always like to set a little bit of a tone of for the respect of those of you in the room, because I know and we know that many of you have not only been hit hard by melanoma, but are still being hit hard by melanoma. And I just want to make sure that everyone in the room knows that there are many people here who are still going through this. So it's very fresh, and there's the roller coaster that all of you who've been there know all about, and sometimes the roller coaster is still going on. So I want to make sure that we have the respect from everyone in the room, that people are in various points in their life with this, and as are their family members and caregivers. And we're going to try to make sure this is a day that's informative, is uplifting, and looking forward. So we're just delighted that all of you are here. So a couple of housekeeping things. There are restrooms at both ends of the building. And we have not only coffee out there with condiments, but we also heard that there will be coffee reloads. Were any of you here when we had coffee go away one year? One of the worst things I've seen happen with that. And then I think we only lost the cream, and it's just like, oh, come on. So we are assured that those will be repopulated, so you shouldn't run out of that. We have several morning speakers. We have a panel for question and answers. Depending on where we are with the schedule, I may let you ask questions right at the end of the speaker or save them, and we'll have a Q&A panel up here at the end. So we do the Science to Survivorship theme, with the science being what's the latest and greatest or unique advances in either diagnosis or treatment of melanoma. Then the survivorship takes those elements of life that go on outside of the treatment time or during the treatment time that we think are incredibly important, and we try to have stories, patient stories told. How many of you have been to the Symposium before? Okay, those of you in the front might want to look around. About half the hands showed up, maybe. So thank you for coming. So does that mean the rest of you are new, or you just weren't answering the question? Okay. So I'm mentioning that because next year I need storytellers. So please come up to me if you are willing to share your story next year. I'd love to get your name and contact and make sure that I don't forget to do that like I did last year. So fortunately we have our storytellers. Any questions about, the other thing is your evaluations in your packet. Please fill out those evaluations and turn them in toward the end of the day, anytime you want. And as much detail as you want. We go through those in detail and try to enrich the next year's talks. And we have Dr. Evan Hall, who's not speaking this year, but he's new on our medical oncology faculty, so I'll publicly invite him to consider giving a talk in the next year or two. And that's about as much guilt as I can put on somebody publicly. His colleague next to him is giving a talk this year. So let me introduce Shelby Monir. Shelby has been with us since the start, I think. 9 years. And why don't you're the Director of Education for the Melanoma Research Foundation. Why don't you go ahead and say a few words? Pretty high. Hold it either way.
Thank you. All right. Thanks, Dr. Bird, and thank you all for being here. As I hope that you know, the MRF exists for you. We can't thank Dr. Bird and his team enough, and all of our wonderful speakers and guests for being here. But the bottom line is the Melanoma Research Foundation exists for our patient and caregiver community. So thank you for all that you do, and thank you for spending your Saturday with us. I have just a few slides. As Dr. Bird mentioned, I am Shelby Monir. I'm our Director of Education at the Melanoma Research Foundation. I have just hit my 9-year anniversary with the foundation, so I'm very lucky to be there and to get to meet patients and caregivers and the researchers on a daily basis. It's an emotional roller coaster, as you probably are aware. And I've been lucky enough to be at the foundation before there were really any drugs approved, and I was there about 10 months or so when we had the first approval in Yervoy. So it's been quite the roller coaster and quite the experience that I am thrilled to be a part of. And just to go through a little bit of our foundation's beginning, we were founded by a patient who realized that there was a huge need for support and research and better treatments. And her name was Diana Ashby. Unfortunately, she succumbed to the disease. We are actually still in touch with her husband, so that's been really wonderful. I got to meet him a couple of years ago. We have a three-pronged mission at the MRF: research, education, and advocacy. Obviously, we want to fund the best, most promising research out there in our peer-reviewed research program. We are thrilled to offer research grants to the best scientists and research teams out there. We have several scientific initiatives, and we also have a large focus on those rare melanoma subtypes. At the end of the month, we actually have a pediatric melanoma symposium where our youngest patients and their families will come and get to go swimming at an indoor water park, and many of them be in bathing suits really for the first time in their lives sometimes. So it's a really great event. We also have a focus on mucosal and ocular melanoma. So if there are any patients with those rare subtypes in the crowd, we are more than happy to connect you with additional resources if you need or would like. As I said, I run our education program, so that includes several patient events like these each year. We also have a variety of webinars and courses, print materials, some of which you saw on the table outside. And we have a great patient forum. It's also known as MPIP, Melanoma Patient Information Page. It's a very, very active online patient forum. It's just a fantastic tool to get people connected to one another and to ask questions and to dish out advice, free advice for what that's always worth, but it's a great platform to connect with others. And then we also have an advocacy arm. And we have an annual Hill Day where our constituents and volunteers will go to Capitol Hill and they will advocate for things like restrictions on tanning beds, increased research funding for the Department of Defense, and a variety of other items. I think one of the newer items is some of the sunscreen ingredient advocacy and legislation points, as well as access to sunscreen in schools. So some of the hot topics include those items, and those are what we call our asks in our advocacy program. And with that, I will pass it back over to Dr. Bird to get us started. And again, a huge thank you. And I don't know if Dr. Bird made the plug for the evaluations at the end of the day, but I'm going to do it again, even though he's nodding yes. Tell us what you think of the event. Be honest. We look at them, we review every one of them, and we make changes accordingly. So please let us know what you think so that we can meet your needs. Thank you.
Great, thank you, Shelby. And thanks to the MRF. They've been co-sponsors along with SCCA of this event since its inception. So let me introduce our first speaker. As those of you who've been here before know that we have a systemic theme, and especially immunotherapy and targeted therapy theme that's been there every year since it became available. And as you heard Shelby, right after she started, or actually right before she started, the first approved drug came out that actually worked for patients with melanoma. So the last 8 years have been incredibly exciting. And we're going to continue the theme. Dr. Joshua Veach is going to come talk to us. Josh is a medical oncologist. He's a scientist and research associate at the Fred Hutchinson here in the Clinical Research Division. He's also an acting instructor in medical oncology. So he sees patients, but he's also a true scientist. So we're delighted to have Josh come up and tell us about the state of the science, I think he's got using T cells to attack melanoma. Welcome, Josh. It's on the screen.
Okay. Hi, everybody. Thanks so much for coming out. And so I'm Josh Veach, and I'm a medical oncologist, and I work in the lab too. And so the thing that I focus on in my work with patients is treatments that go throughout the body, both to prevent melanoma from coming back after surgery and to treat people where they have metastatic disease where the melanoma has spread. And I'm going to talk mostly about immunotherapy during this talk, but I want to give a quick shout out at the beginning to the other way we can treat melanoma. So about half of melanoma has the BRAF mutation. And the BRAF mutation can be targeted with specific drugs that inhibit that abnormal protein that gets activated and drives growth of those cells. Those patients can be treated with BRAF-targeted therapy, or they can be treated with immune therapy. And patients that don't have the BRAF mutation, we use immunotherapy. And there have been now 3 different combinations of drugs that target this abnormal BRAF protein that leads to, so normally what happens in your cells is that growth signaling is only turned on when it's supposed to be turned on. And people who have these mutations in BRAF will have an abnormal protein that's on all the time. And so it signals for the cells to grow even when they shouldn't be growing, and that causes them to grow out of control and can cause melanoma. And there are drugs that can fit in and bind to the BRAF protein and prevent it from doing that. And then there are also drugs that can bind to other members of this pathway and that can help the BRAF drugs work better. And these have been a lot of help for a lot of patients, and a lot of people in this room have probably been on some of these medications. And I wanted to sort of mention them, but most of my talk is going to be talking about immune therapy. And I think immune therapy is largely responsible for a huge amount of progress that's happened in this disease in the last decade. So if we look at people who had metastatic melanoma that had spread throughout the body, 10 years ago, we could tell those patients that the majority of them could expect to live less than a year. And the initial clinical trial that approved the drug Yervoy that we talked about here, the control arm in this trial, the majority of patients had passed away by a year, and the vast majority of them had passed away by 2 years. And Yervoy was a clear improvement on this, but it was a small improvement. What we've seen more recently is that with newer immunotherapy approaches that we hope are getting better with each passing year, this is now from a couple of years ago, newer immunotherapy approaches, now more than half of patients are living 3 years. So from more than half of patients not making it to a year to more than half of patients making it 3 years for people who have metastatic melanoma, there's been a huge amount of progress. We still have a long way to go, but we do think that a large fraction of these people that are making it to 3 years can make it a lot more. And we're really happy about that, but we still have work to do. And so I want to talk a little bit about the idea of how immunotherapy works. And so the immune system's main role is to get rid of viruses. And so when you get a cold, the cold virus invades cells in your nose and your throat, and it hides out inside those cells and it hijacks them and uses them as factories to make more cold virus. And the cold virus spreads to other cells, it spreads to other people. And in order to get better, you have to have an immune system that can get rid of these virally infected cells. And the thing in your immune system that does that is T cells. And so T cells go around and scan the surface of all the cells in your body to see if any of them might be infected with a virus. And the way they do this is that every cell in your body chops up everything inside of it and brings little pieces of it to the surface. And your T cells look to see if any of those little pieces are foreign, not part of your normal, not part of what should be in your body normally. And then if it recognizes anything foreign, it can set the wheels in motion for events that lead to those cells getting killed, sometimes directly by the T cells themselves. And so this process is how you get better when you get a cold, is your T cells figure out which cells are infected with a cold virus and eliminate them. And so they can't make any more copies of themselves. And the way your immune system is able to recognize self from non-self is very interesting too. And it uses something called a T cell receptor that your body makes billions and billions and billions and billions of different possibilities for this T cell receptor. And the T cell receptor is the thing that fits like a lock and key to the piece of the inside of the cell that's brought out to the surface. Your body makes billions of these, and then it takes everyone, it makes them at random. And it takes everyone that doesn't recognize the self, or that does recognize the self, and it gets rid of them. So now you're left with billions of different T cells that are waiting to recognize something that isn't you. And if they find something that isn't you, once they go out into your body, they know that that's probably an invader, it's probably a virus, it's probably something bad. And this specificity of this lock and key is what allows T cells to work and what allows T cells to recognize self from non-self. And so for a very long time, people have known about T cells in infectious disease, and people have speculated about T cells in cancer, because cancer is different from self. There are genetic changes, there are abnormal things that happen in cancer cells that potentially T cells could see and recognize this isn't right and try and eliminate the cancer cells. And there were a couple lines of evidence going back a long way that this might be the case. And one is that people who have immune suppression because they've had an organ transplant or a bone marrow transplant are at higher risk for a lot of types of cancer. And patients who have HIV/AIDS are at higher risk for cancer too. And so that, again, was a clue that the immune system might be involved in controlling cancer and could be potentially involved in treating cancer. The other thing that we knew for a very, very long time, but it was that there were rare cases in melanoma where a primary melanoma that was there would just shrink and go away. And oftentimes when it shrank and went away, there'd be this little rim of sort of depigmented skin around the melanoma that was shrinking away. And if you did a biopsy and looked under the microscope, you could see that the area where the tumor was melting away was full of T cells. And so even before we had immunotherapy, even before we really knew what we were dealing with, we knew that there were some cases of melanoma where the immune system could attack it. Which raised the possibility that maybe the T cells that you need to eliminate the melanoma are already there. Maybe they're already there in your body and they just don't work. And there was a lot of basic research that was done over many, 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 many years to go from the insight that you have this T cell receptor that recognizes the specific thing that turns it on to realize that there are a lot of other very, very complicated signals that work on the T cell. There's signals that turn the T cell on, and there's signals that turn the T cell off. And this is really important because if a T cell runs amok in your body, it can do a lot of damage. And so you need to be very, very careful about tuning when it turns on and when it turns off. And your body does this by having many, many complicated signals that can stimulate T cells and say, yes, this is an infection, it's time to take out those infected cells. And it has signals that say, no, wait, stop. This is not an infection. You don't want to have an autoimmune disease. Turn it off. And back in the 1980s and 1990s, people started understanding what some of these signals were that were positive signals. And one of them was used at the National Cancer Institute, high-dose IL-2. And what they found, this was a treatment that when patients got it, it made them very sick in the short term. And a small fraction of patients would have durable responses where their metastatic melanoma would shrink away and in a lot of cases not come back. But it wasn't very many patients, and this treatment made people pretty sick. There might be some people in this room that have been through this treatment or known people who've had this treatment. But in the short term, it makes you quite ill. Then there was work done more recently, first by Jim Allison, who won the Nobel Prize this past year, on some of these negative signals that take T cells that are activated against something and turn them off. The way I can think about this is that it's the tumor putting up a stop sign and saying, no, don't kill me. And what would happen if you took a drug and you blocked one of these signals saying, no, don't kill me? Now the T cells that were already there could function and start killing the melanoma cells. And the first one of these negative signals that was identified was CTLA-4 by Dr. Allison, and then subsequently PD-1, which is the one that gets used most clinically now. And so what these inhibitors do is they prevent the tumor from being able to turn off a T cell response that's already trying to kill the tumor but not able to because of these stop signs. And this is a patient that I shared with Dr. Bird that Dr. Bird is going to be talking with you about a little bit later in a little bit of a different context. But on the left here is a PET scan, and it's through sort of a slice of the body like this. And the part at the top here, it has a tracer that has a molecule that's like glucose, and your brain normally takes up glucose. So this is normal that the brain is sort of red hot here. But this big tumor under the armpit is not normal. And that's a cantaloupe-sized tumor that was a melanoma that was treated with a combination of these two immune checkpoint inhibitors. And over the course of a couple months, the cantaloupe shrank down to about the size of a kiwi. And then Dr. Bird took out the kiwi, and when they looked at it under the microscope, there were no melanoma cells left. And so this is the potential in some cases when immunotherapy works well, that it can work really well. And the thing that made us really excited about immune therapy from those first trials with Yervoy that only affected a small number of patients is that the patients who got benefit from immune therapy often had benefit for a really long time. They went into remissions that were durable and lasted years and decades. Whereas a lot of cancer treatments over the years had been things that worked for a period of time and then stopped working. This line about people surviving with metastatic melanoma has gotten higher and higher over the last couple of years, and we hope to get it all the way to the top. But there are a good fraction of patients that had this previously incurable disease that are now surviving a long time because of immunotherapy. And again, we haven't followed the people who've been treated with the more modern agents for that long. It's only been a couple years, but our hope is that as we get further and further out, that more and more of these patients will be in remissions that last for years and maybe even decades. That's our hope. And once we developed these immunotherapies for the treatment of people who had metastatic melanoma, we also moved it into people who had surgery but had high risk of recurrence. And a lot of people in this room have probably had treatment in this setting. I know at least a couple. And we found that giving these drugs can help reduce the risk of recurrence. And so a lot more people are being treated with these immunotherapies in that setting. And a lot of people in this room have probably also dealt with the side effects of these drugs, which is that blocking the stop sign blocking the stop sign that keeps T cells from running amok can sometimes be bad. And sometimes you can have T cells that attack normal tissues in the body that shouldn't, and people who can have autoimmune diseases that can affect every part of the body, including the digestive tract, different internal organs, the thyroid gland, the pituitary gland, other things like that. And we're working on treating these things too. We think for people with melanoma, the benefits of having these treatments outweigh the risks in the vast majority of cases. But this is something that we and many people here have probably had to deal with some of these side effects. But the problem that we have right now is that some people still don't respond to these treatments. For the people who respond, it's great. But some people don't respond, and the question is, what can we do for those people, and can we get the immune system to work for those people too? And that's a really big push of the research that we're doing right now. And so there's a lot of research into saying, can we do other things with these T cells to help turn them up or to help take the brakes off of them? Are there other pathways other than PD-1 and CTLA-4 and IL-2 over here? Are there other pathways that we can combine? And can we combine them in the way where we find the right balance where the T cells attack the melanoma but they don't attack the rest of the body? And so this is a really, really complicated slide that's in reality even more complicated than this, saying that there are really a lot of these positive and negative signals. And so right now, scientists and drug companies are trying to combine different ways to turn T cells on and turn T cells off and try and find that right balance that will turn them on in the right way without turning them on in ways that will attack things that aren't the cancer. And so we have several trials that are combining our sort of workhorse, which is the PD-1 inhibitor, with investigational things, like, for example, a LAG-3 inhibitor, or something that activates one of these other pathways here. So we either block a pathway that we think turns T cells off, or we activate a pathway that turns T cells on. And this is the focus of clinical trials that sort of periodically are open and closed here, but this is a big strategy that people are pursuing right now. Another strategy is that when you use an immune stimulant and you give it throughout the body, it can cause a lot of toxicity. It can cause inflammation, it can make people have fevers, it can make people sick. And so one idea is to give immune stimulants locally at the site of one of their tumors by an injection into the tumor. And when we do that, the idea is that we can activate the immune system in that tumor, and those T cells can then go and take out the other tumors too. And so we have several clinical trials that are going on right now that do just this, where one of these inflammatory agents is injected into one of the patient's tumors in hopes that it will provoke an immune response elsewhere. Another strategy that we're taking is to try and say, what if people just don't have enough of these T cells that recognize the tumor that are there? Can we make more of them? And one way to do this is to have a surgery where you take out one of a patient's tumors, cut it up into pieces, put it into a petri dish, throw a bunch of T cell growth factors on it, and just grow out the T cells from the tumor. A lot of those T cells recognize the tumor, but they're too dysfunctional. But if you give them all these growth factors, they can grow and they can function. And then you can inject those cells back into the patient. And this is also a strategy that's been used for a couple of decades, first at the National Cancer Institute. And more recently, we have a clinical trial that's open right now that's using this approach in patients with melanoma that haven't responded to other treatments. This is called tumor-infiltrating lymphocyte therapy, or TIL therapy. And then another strategy that people are taking now to try and see if we can make more T cells that recognize the cancer is to try and make a vaccine that can stimulate T cells against the cancer in the same way a vaccine can stimulate T cells against an infection to prevent you from getting an infection. And one of the big problems with making a vaccine like this is it turns out that the important things that T cells see in melanoma cells that distinguishes self from non-self are mutations in the melanoma that are unique to every patient. And so they're hidden in the genome and they're different for every person. And so the only way to find what those mutations are and to be able to make a vaccine for that patient would be to sequence almost the entire genome from that patient's tumor for every patient you were treating, which sounds ridiculous except for the fact that sequencing has gotten a lot cheaper than it used to be. So 20 years ago, you had to be Jeff Bezos in order to have your genome sequenced because it cost $100 million. And it was something that required huge teams of people, huge amounts of time. And the technology in this has really been amazing in that now we can sequence essentially the whole genome for $1,000. So it's gone from 100 million to 1,000. $1,000 is still a lot of money, but it's in the ballpark of something that's realistic to do for an individual patient. And so what's happening now is that there's a clinical trial that's about to be open here where patients will have a biopsy of their tumor. It'll be sent to a lab. The important parts of the genome will be sequenced, compared to the normal genome for that person to see what's different between the melanoma and the patient. And then using computational algorithms, using computers, we'll make guesses about what the immune system's likely to see. And then a vaccine will be made specific for that patient. And then it will come back and the patient will get that vaccine. It's not quite Star Trek technology yet because this process doesn't happen instantaneously. It takes 1 to 2 months. And during that time, the patients will be treated with the standard of care therapy before the vaccine is ready. But the idea is that this is something that 5 or 10 years ago, we couldn't even imagine describing doing this sort of thing. But it's possible now with current technology and is part of a clinical trial that's going to be open here, hopefully in the next month or two, where each patient will get a personalized vaccine trying to stimulate T cell responses against foreign antigens in their tumor that are unique to only their tumor. And then another strategy that we can use, again, if we don't think that there are enough T cells that can target the tumor, is that we take the patient's existing T cells that don't recognize the cancer and we reprogram them so that they recognize the cancer by putting a T cell receptor that we know recognizes the cancer into that T cell. And so in this way, we can maybe take people where even a vaccine might not work, in theory, and get a T cell response that could work against the cancer. One problem with this approach is that I was just telling you that most of what the immune system sees in cancer cells as being foreign is unique to every patient. And so one of the approaches that we're taking is we actually found a T cell that recognizes that common BRAF mutation. This is my own work from my lab. That recognizes this BRAF mutation that's not just present in one person's tumor, it's present in 40% of people with melanoma. And so the idea here is that we could take the T cell receptor out of that patient's T cell, and we could put it into a new patient's T cells and put it back in, and both understand what that T cell does and hopefully have that T cell mediate a useful effect for that patient. And we know that in a Petri dish, this T cell receptor works, and we're hoping in the next year or two to be able to test it to see whether or not it can help patients. This particular type of T cell is a helper T cell. The killer T cells are the ones that directly recognize tumor cells and kill them, and helper T cells are the ones that orchestrate the immune response and sort of coordinate the responses of other cells. They're very important. They're the cells that you lose when you have HIV/AIDS, and so they're very important for the immune response, and they're important for anti-cancer responses. And we're hoping that this clinical trial of a T cell that targets mutant BRAF will allow us to understand better how these helpers might work in people who have melanoma. And so the idea behind this trial is that the patient would give a blood sample. We'd take the T cells into the lab and we'd re-engineer them so that they had the T cell receptor that recognized the melanoma. We'd take these reprogrammed T cells and we would grow them to very, very large numbers in the lab. You can grow them up to 1 billion cells. And then you'd give those cells back to the patient. And again, we've seen that these cells can have activity in a Petri dish against melanoma cells, and we want to see whether or not it can have activity in people. This is an approach that, because of the way the immune system presents these antigens, is going to be available for a relatively small slice of people with melanoma. But if it works, it's something that could set a paradigm for treatments that we could use in larger numbers of people too. And so for this particular clinical trial, we'll be looking for people who have this BRAF V600E mutation, and they'll need to have the right type of molecule that's used in bringing the pieces of the cell to the surface that are called HLA or MHC molecules. That'll be in about 20% of people. And so we'll need to look at a lot of people to find people who are eligible for this, but we hope to start enrolling in a year or two for using this particular clinical trial that I'm working on. And so I hope that this has been helpful. It's sort of been a high-level look at a lot of different things that we have going on in terms of clinical trials and approaches to doing immunotherapy. And I just wanted to thank you guys for your time, thank my colleagues in the melanoma group, the Melanoma Research Foundation, and the biggest thank you to patients and their families, because without patients and their families participating, being involved in the science, being involved in these clinical trials, we wouldn't have these treatments and we wouldn't be able to develop them. And so a big thank you to all of you guys.
How often do you see speakers under time? I think in the Q&A session, we'll have more time for Q&A. Do you have some questions now, Dr. Beach? Hopefully you heard several new things that you didn't hear in previous symposia about the work he's done and others. Question in the back?
Yeah, I'm wondering if you see that vaccine being preventative or
It's going to be tested first in the setting of people who have metastatic disease. Potentially, it could be something that could be useful in the high-risk setting too, where there's a high risk of a tumor coming back after surgery. But this particular trial is looking at people with metastatic disease.
Is there any specific identifier for that small population? You said that the melanoma actually got attacked by the T cells and it kind of cleared the skin area. And what's different about that population than people whose melanoma doesn't get attacked by the T cells?
Repeat the question.
Yeah, so the question was whether or not we know what's different about the people who either respond spontaneously like that, which is rare, versus also people who respond when we give the immune therapy drugs versus the people who don't. A lot of people are working on those questions. There are some tests that can predict a little bit about who's going to respond to immune therapy and who isn't. One of those tests is to look to see how many mutations, how many of these genetic differences that a patient might have in their melanoma relative to other patients. And people who have more genetic changes, it's more likely to be recognized by the immune system. There are other markers that you can look at under the microscope and see how much of a T cell response is already there before you start treatment. But it's something we're just beginning to understand, and right now those tests aren't good enough that we use them as a way of, or that at least I personally use them as a way of saying this person should get this treatment and this person should get a different treatment. But it's a very good question, and a lot of very smart people are working really hard on that.
So are any of these clinical trials that are underway or are planned, are they going to include patients who have some of the rarer types of melanoma, such as mucosal melanoma or ocular melanoma, or are there other trials that are intended for those patients?
Yeah, so that's a really, really good question. So many of the trials will include, most of the trials will include patients with mucosal melanoma. Many of the trials will not include, although not all, will not include patients with ocular melanoma. And we are in need of more research in ocular melanoma for sure. Sometimes if we don't have a clinical trial available here, I've been sending patients to other centers to go on clinical trials. There are definitely immunotherapy trials going on in ocular melanoma, and we're interested in trying to find more here. At present, we don't have any specifically for ocular melanoma, but that's a good question and a very important point to bring up.
So if you were put you on the spot here, if you were to look at your crystal ball out 5 or 10 years, what do you see as maybe the most typical way of, now it's mostly immunotherapy to treat a lot of melanoma. So what does that look like, do you think, as a most common way of treating melanoma 5 or 10 years from now?
The question was for me to look at my crystal ball and see if I could guess about how melanoma is going to be treated in 5 and 10 years. And I can tell you what I'm hoping for, which is that these personalized approaches that either make vaccines that are targeted for a specific patient's mutations, or even further out there ideas where you make a T cell, the way I'm saying to make it for lots of different people, but you make a T cell for one person. My hope is that those sorts of strategies will be viable and that they'll work. And that that's going to be the way we're going to treat the subset of people that don't respond to immunotherapy now in 10 years. That's my hope. But
So I have a question for you.
yeah.
So with the sequencing of the whole genome of every tumor, every patient's tumor coming in, you made it sound like that's a new project. If their patients in the room have already had their tumors removed, who are still struggling with disease or worried about recurrence, is that tissue that can be done, can those studies be done off the paraffin-embedded tissue? Does this need fresh tissue? And if somebody wanted to have their melanoma sent to your lab, what do you answer to that?
So this particular clinical trial, you can do sequencing off of fixed tissue that's been in paraffin, which is what people have if they've had a resection in the past. It's better if there's more, if it was something like a big lymph node that was taken out, rather than a lymph node that had, a couple of melanoma cells in it. Fresh is always a little bit better, but we definitely can do sequencing, and they can do sequencing for the trial off of sort of old tumors that have been taken out.
So if anybody has an personal interest in that, you can check with them during
Yeah.
break time. Other questions? Still a little bit ahead of time. Any other questions? One here and then one here.
How do you treat, and at what point do you stop the immunotherapy with an adverse reaction?
So that's a good question, and it depends on what the adverse reaction is. There's some types of adverse reactions where, for example, the immune system will attack the thyroid gland and make patients need to take thyroid hormone replacement. Typically, when something like that happens, it stinks because they have to take thyroid hormone replacement now, usually for the rest of their lives. But it's something that we typically will keep doing treatments for because we think that the problem has sort of happened and is past and can be dealt with. There are other types of problems like severe immune reactions with the digestive tract that can really make somebody sick, where we say we probably shouldn't do this anymore and stop it. And so it depends on sort of how severe the immune reaction is and what we think the danger of going back to it, and also how somebody's disease is going.
Question here.
I was just curious about the HLA type. I think that you're supposed to that in your hand. Like, what are you looking
Yeah. So every time we find one of these T cell receptors, there's sort of two bits about it that are specific. And one is the actual little piece of the protein that's been taken out, the peptide that's been taken out to the cell surface by this molecule. And the other is the molecule that's doing the carrying. And everybody has a different set of those molecules, and evolution did that so that we could better have our population survive really bad infections, so that people would have a variety of different ways to present to the immune system. But what it means is that the particular T cell receptor that we got from this particular patient recognizes the mutant BRAF only being carried by one of these types of molecules. And so this particular type is found in about 20% of people, just on average. Did that?
B27 or what?
This is it's a class 2, and it's class 2 DQB1 0302. Yeah.
Sounds like today you're working on a recipe to address a specific patient. Do you look to a time when the technology will be such that you can come up with a recipe that fits a wide population of patients?
That's the hope too. And I mean, with some of the treatments that work right now, it's the same anti-PD-1 drug that goes into everybody and it can be effective for them. And so a lot of the approaches that are being taken aren't personalized, and the not personalized ones are easier to work with because it's giving the same drug to everybody. But yeah, we're definitely working on that too.
But also contains the expense.
Yeah.
How does your treatments play into a person having another cancer that's non-curable? Is it as effective or?
So clinical trials often have the bad habit of wanting the people that they study in the clinical trials to be as simple as possible. And so oftentimes clinical trials will not want to enroll somebody who has a second cancer. But once we get past clinical trials and we say, okay, we have these drugs, I have patients that have more than one cancer that I'm treating right now, and these drugs can be effective in them too.
How does it affect the other cancer too? Like a slow-acting cancer, does it activate it or, you know?
I think it depends on the specific situation. There are some cancers that can respond to some of these drugs in the same way that melanoma can, and there are cancers that don't. We usually, in most situations, don't think that it hurts the other one. Yeah.
For people who are getting immunotherapy, how soon in their treatment can you predict if they're going to be the 50% who make it to 3 years or 50%?
So typically what we will do is it takes a little while for us to be able to see the effects on a CT scan because initially what happens when treatment is successful is that T cells run into the tumor and so the tumor doesn't shrink right away. And so typically we will look at 3 months, and if we look at 3 months and the tumors are shrinking, that is a good sign that those patients will do well in the long run, but not a guarantee. And so that's sort of the time frame that we typically are able to find something out, although oftentimes the answer is sort of mixed and it depends on the individual situation. We're trying to work on ways of being able to tell whether things are working earlier by doing sort of more fancy types of imaging techniques or biopsies to be able, because we think at the microscopic level the action's happening faster than 3 months.
I've got a follow-up to my wife's question. Your research on T cells, manipulation of T cells, it is a crossover for other cancers. So does SCA coordinate your efforts with the specialists, like in her case is WM? Because you are manipulating T cells, so isn't that kind of universal to all cancers?
So there are definitely so the treatments that were first developed in melanoma are now used very widely, which is why you can't watch a football game anymore without seeing an Opdivo or a Keytruda commercial. Because these drugs are used in cancers that are even more common than melanoma now. And so there's a lot of interest on the research side about looking at lots of different types of cancers. The strategy might end up having to be a little bit different for different ones, but some of these same sorts of approaches could be more universal.
What is the nature of the melanoma that made it such a good candidate for this type of intervention? Was it the dire consequences of it, or was it something about it?
Yeah. The question was, what's special about melanoma that maybe made it a better target for immune therapy than other cancers? I think the quick answer to that is that we think that the ones that are the cancers that are seen the best by the immune system are the ones that have the most genetic changes in them. And so the sort of classic examples would be lung cancer caused by smoking. The carcinogens from the cigarette smoke have been causing lots of mutations. And in a lot of cases with melanoma, it's a lifetime of UV light exposure causing lots of genetic changes. That's sort of the simple answer. And the more complicated answer is that it's more complicated than that. It might have something to do with the way the immune system works in the skin. And something about the way the individual melanoma cells are relative to other types of cancer.
Question right behind.
I preface what I'm going to say by I understand that individual anecdotes are not necessarily important in science. But 15 years ago, I was diagnosed with vulvar melanoma. I was told at the time that diagnosis to death was probably 14 months. That was 15 years ago. At that time, I became aware of some work that was being done with low-dose naltrexone, very low dose, which is an immune booster. And I am still here 15 years later, and I'm 85 years old. I prescribed for myself low-dose naltrexone. Now, at that time, I had to send away to Kitchener's to get it. Now you can get it at any compounding pharmacy, and I'm just saying that I think it should be investigated.
Oh, thank you.
So I have a question for you. So how about patients who have an altered immune system, either a hyperactive immune system such as rheumatoid arthritis, where they already have autoimmune starting point, one end of the spectrum, and conversely, patients who are immunosuppressed, transplant, solid organ transplant patients or others. In general, how would you approach those two types of patients with this discussion?
So most of our data that we have from the clinical trials, because they like keeping things simple, didn't involve treating patients in either of those categories. But in the real world, we do treat patients in those categories. And what we found is that when you treat people who have pre-existing autoimmune diseases with the immune checkpoint inhibitors, there is a risk of their disease flaring, but not a guarantee. And so if we think it's appropriate to use the treatment, we do, but we know that there's a higher risk of side effects. In the case of people who have immune suppression, theoretically, we think that the treatment might not work as well. We would like to find ways to reduce the immune suppression when we can, but again, often it's something that we use if we think it's best for the patient.
Time for a couple more questions. These are all really good questions. Right here?
How does D3 factor in? D3 is for your skin. You need to be out in the sun to get that. My daughter has melanoma and her D3 is super low. And that's when it kind of triggered up. Does that have something to do with it?
Yeah, so the question was about whether or not vitamin D, which is something that the sunlight helps to activate, could be involved in melanoma. And that's a good question and not one that I have a good answer for. I'm sure it's something that's been studied, and it's not something that I know about personally, though.
We do have 2 talks from now, a dermatologist, who I bet would have some comments to make.
Oh,
Yeah.
Your internet may not work in this room.
Yeah.
Yes.
It's a pretty basic question, but I'm new to this. On your charts for longevity, you show originally less than a year, and it's improved to 3 years, and it's gone beyond that. But what I don't understand is, where do you start the time? Is it from
So So the question is when I'm saying a certain length of time, where does that time start from? And in the case of the clinical trials, it was when they enrolled in the clinical trials. And for most of those clinical trials, particularly the more recent ones, it's people with a new diagnosis of stage 4 melanoma.
Yes.
I recently was in the clinical trial that had 2 years with lag at the PD-1, which is here. And I started with that with a bunch of tumors that were underneath my skin. And most of them went away. But a few, and I'm done with the trial now, but I can still feel some of them. And I think they're going away. Is there any, are they active in there? The ones that I can feel, or are they just dead and go away eventually?
So I think it depends on your individual situation. If you're worried about something, you should, see your dermatologist or your doctor about it for sure. But in these situations with these treatments, sometimes the lumps don't entirely disappear, even if there are no melanoma cells in them anymore. And the way to be able to tell is to do a biopsy of them. But in that example that we gave, that Dr. Bird's going to talk about even a little bit more, this cantaloupe turned into a kiwi, but there was still this lump there. And then under the microscope, it was a scar. And so that can happen, but I think if there's something that you were concerned about, the solution would be to do a biopsy and get a piece of that tissue and see what it looks like under the microscope.
Because they're basically going away.
So one thing to mention on those survival curves, again, he said that greater than 50% of the patients were gone at a year formerly, and now it's up to 3 years. But look at the shape of those curves, right? These are not survival curves that are going down and still going down. They are leveling off and sometimes almost completely flat, and there's a lot of patients in that. So that at least 3 years. Don't just think, boy, now we got 3 years. This is something we're very quietly, so I'm saying cure, very quietly using a C word for what this may mean. So it's more hopeful than, well, now I could go 3 years.
Yeah. We can't talk about the 10 and 20-year survival rates with the PD-1 inhibitors because they haven't been around that long. But we can say that there were people treated in the early 2000s with Yervoy who were still in remission, and people who were treated with high-dose IL-2 in the early 1990s that are still in remission. And our hope is that a good chunk of the people who get good deep remissions with the PD-1 inhibitors can be like that. We don't know for sure.
One more question.
And this may be for another time in the conference, but I have stage 4 melanoma under apparently great response to Opdivo. And I'm from Bellingham. In Bellingham, they don't seem to know what's happening here. I'm curious about how the research people let outside doctors and clinics and so forth know what's available here, because it was a total change of treatment and everything when I came to SCCA. They don't seem to know.
We do our best to get the word out. I think it's something where, oftentimes what people will do is they'll come here for a consultation, and even if they're at a place where, let's say they're going to be treated with Opdivo, you can get Opdivo up in Bellingham, and that's often easier and less of a hassle, dealing with traffic and those sorts of things. And then we can also potentially be involved either if something happens or to let people know about other alternatives. I don't think that really answered your question, though.
Let me expand on it a little bit.
Yeah.
So we are not the center of the universe for all of melanoma treatment. No place is. The main thing is we try to stay as close on the cutting edge as we can. Partnering with the Fred Hutchinson is a huge advantage that we have. SCCA has a lot of medical outreach. We actually run a big, at least once a year, a big cancer symposium that everyone is invited. These are primarily MDs and advanced practice providers as an ongoing continuing medical education. To me, the big advantage we've got is we have specialists within medical oncology who focus on a disease. And when you focus on one thing, you get pretty good at it, and you're really good at finding out what's out there. I think a lot of medical oncologists with a general practice, you can be a really good medical oncologist, but it's extremely hard to stay up on everything. Same thing with surgery. If you're trying to do all of surgical oncology, very difficult to know everything. So I think that's one of the advantages that we've got, but we certainly don't want to be best kept secret around. And most providers are pretty good about seeking out information. And as patients and advocates for yourselves, educate your providers to look for things that you come with. Just like when you come here, you can say, I heard at the NCI they've got this. What's your comment on that? So every place should be open to listening, and if they're not, you might want to say thank you for your time and walk out the door. But it's, I would say the majority of medical oncologists are aware of SCC as a resource, certainly in the state of Washington. And we may hear about OHSU because we have Dr. Barr here who can mention what they've got down in Oregon. But I think in general, it's the specialists that focus on this every day and have the connection with the laboratory that is a huge plus for us. Dr. Beach, thank you very much. Outstanding talk. While she's putting the slides up, so this is a new topic for me to present because it's a little bit just getting going, but as a surgeon, I'm going to try to convince you that I want to talk us out of needing me for this disease. I'm fine doing something else. If I don't have to cut out cancer, I'm fine with that. And I think we're on the way to that. But it's interesting that on this same journey, I'm also ending up with patients coming to me who I wasn't going to operate on. So there's the two ends of I'm trying to get patients who won't need me, but others who need me because that's the only thing left after the other treatment didn't quite get rid of everything. So I'm going to cover the concept of neoadjuvant treatment in patients with melanoma. And this is not new in the cancer field. And did you take the, did I take it? Where's our little stick? All right, hold on. Here it is. Getting smaller and smaller. Pretty soon you'll just be able to do it all holographically and say, now look at this and look at this slide. We're getting close to that. Okay. So, and this really comes from the concept that when cancer was first diagnosed, we really had surgery as the only option. Now we're talking 70 years ago. And then radiation therapy was another option, but chemotherapy did not exist at all. But now we know that surgery alone doesn't always do the job. It certainly can with the majority of patients with newly diagnosed melanoma, but there's often a concept called adjuvant treatment that you may have heard of for a variety of diseases. It's been around for a long time. For example, with breast cancer, we've had anti-estrogen hormone therapy, tamoxifen, has been around for 40 years. And so these adjuvant treatments are in addition to usually surgical removal. So we've had that around a long time for certain diseases. We haven't had much in the way of melanoma, except you heard about IL-2, and we've had some drugs, dacarbazine and others, because they didn't work. So people weren't really interested in talking about this, because why would you try something up front that doesn't work? Why would you try it at all? So these concepts are not new, but the concept of neoadjuvant systemic treatment is one for melanoma that is new, because we now have these drugs since 2011 that are effective. And I'm calling it systemic treatment instead of just the word chemotherapy, although most people think of neoadjuvant as chemotherapy, as we use for breast cancer. But with melanoma, it's really going to be neoadjuvant, either immunotherapy or the targeted therapies that you heard about. So we haven't done this until fairly recently, but now we're getting quite intrigued because it's been very successful for a variety of reasons in other cancers. So why even consider doing this? Well, if you're going to commit a patient, or at least have the discussion up front that surgery alone is less likely to get rid of your disease as surgery plus X or Y, such as immunotherapy or radiation therapy, if that's the discussion, then what would be the potential advantages of flipping it? If you're already talking about both, So here's some, this is my cancer hat talking, not my surgeon hat talking. The life-threatening problem with cancer is rarely the local tumor. It's the tumor that has gotten loose somewhere else in the body. That's why patients die of cancer generally. So the neoadjuvant treatment approach means if you get that started, you are giving treatment toward the life-threatening disease at the earliest possible time. You're not waiting for the patient to see the surgeon, you're not waiting for the surgery to be scheduled, have the surgery, recover from the surgery, and then get it, because the surgery only treats what you aim it at or cut, just like the radiation only treats where you aim it. So one reason would be, if that's the life-threatening disease, why not get it going early? And it does treat the primary tumor as well. You're not leaving the primary tumor alone. Patients with breast cancer, sometimes when we have this discussion, they say, look, I want this thing out of me. This is gone. And the flip side is, why not treat all of your disease, and we're actually going to know if it's working because there is measurable disease, because there is measurable disease that's still there, and you can see if it's working. If you do it the other way around, where you give adjuvant treatment, so you've taken the tumor out, but you've already agreed we want something else, you actually have no idea if it's working against tumor. You do know the side effects. You get those in spades. You got those right up front. You know that, but you actually have no idea if it's working. If you think about it, the best case scenario is if melanoma doesn't come back, it may have worked. Well, if it doesn't come back, it may not make a lot of difference whether it worked or not, but that's the best case scenario. And think about it, if it wasn't working, you're taking the entire course of that treatment for whatever duration, and you had no idea that it wasn't working, if you do it that sequence. So that's, again, just another kind of cancer hat argument. So is it safe to do it that way around? Because I just had a debate with one of my fellow medical oncologists in our melanoma group, where I was pushing for this, and the medical oncologist was pushing for the surgery first. So that was our debate. Kind of seems a little backwards, doesn't it? And one of the slides that Dr. Baccia had, he's spoken here before, is surgery, a chance to cut is a chance to cure. That's usually a surgical slide. I didn't put that slide up. He put that slide up. Because there is concern that you might lose the opportunity to remove that disease if the treatment doesn't work. Very valid. Same thing with breast cancer. I have the advantage, I also treat patients with breast cancer. I've been through this story 25 years ago. We've been using neoadjuvant treatment for breast cancer for 25 years. Most of my medical oncology colleagues, now some of the more recent trainees also have treated breast cancer, so they're a little more tuned in with me. Some of the other contemporaries my age haven't treated in medical oncology, haven't treated breast cancer for years, and to pull them into this discussion is an interesting pull that I find just a little bit head shaking. But I'm going to continue my conversation with that, and I think I have two advocates in here that I'm pulling them along as well. So we know that in certain diseases, for example, with patients with rectal cancer, you can, by giving chemotherapy and radiation up front, you can actually shrink the tumor to the point where when surgery is done, you have a better chance of getting a clear margin. In other words, less local recurrence. You also will know what the response is. And sometimes you can actually do what's called sphincter sparing surgery, where you can take a limited part of the rectum out and leave the sphincter so a patient doesn't have a permanent colostomy. Very big deal for that. In breast cancer, I'll give you an example of what we've done with lymph nodes. So a patient comes in with positive lymph nodes, clinically positive lymph nodes, gets neoadjuvant treatment, and those and they're biopsy proven to be positive. And then you get the treatment and the nodes go away in terms of looking abnormal. They still have lymph nodes, but they look normal. We're now doing a trial where we're able to take out only a sentinel node biopsy, and most of you know about that, and I'll talk about that in a second. And if the sentinel node has no residual breast cancer in it, we're able to spare some of those patients the complete lymph node removal. So less morbid surgery in patients who respond, ideally under clinical trial setting. And this is where I agree completely with Dr. Baccia in his argument in the debate. We really should try to do these on clinical trials. Now, surgeons are kind of simple-minded people, and the Superman label may not be very appropriate for that, but the fly swatter is, because that's a knife. And the good news is The patients I see, at least 80% of patients I see, I'm going to, I think, cure with the surgery alone because it has presented at an early enough stage, it has not gone anywhere. So the thing we're not talking about today, but all of us really need to focus on is prevention. Let's not even have to be in this room. That would be ideal. But the good news is skin awareness. People look at each other, the sun comes out, they start looking at their backs and things, and there's always a flood of patients that come in somewhere around the fall because they couldn't get into their dermatologist's office for 3 months. So there's a flood of new diagnoses coming in the fall because people have discovered things during the summer. So we're better at looking at our skin. We're better at using sunscreen. We're better at educating our children to not get bad burns. So that's helping. So I'm not really talking about this group of patients because we already have good treatment and with reasonably low morbidity procedures to do that. And for example, this is a nice flat melanoma, 48-year-old man, a 1 centimeter lesion. You can do a punch biopsy or take it off to make a diagnosis. We want to know how thick is it and if it's melanoma or not. And those patients can be cured, again, with a procedure to do that, with a wide excision. Some of you may have been operated on by me in this room and know about the lazy hurricane kind of procedures that I do. But you can take out a chunk of skin and end up with it's a substantial scar. You can call it as a bad scar. You can say, we'll wear this with a badge of honor and say you should see the other guy, whichever way you want to put it. But this will take care of a lot of those early melanomas. But what about one like this, 2.5 centimeter, and you can see that 3D component, that raised component. This is not going to be a thin melanoma. And you do a punch biopsy or an excision, and the thickness in blue there, 3.4 millimeters. This is an intermediate thickness melanoma, pretty much on the higher side of that. There's also ulceration present. So this is a patient, same surgical management of how much or the skin to take off, but these are patients we would add a sentinel node biopsy that is that first node that drains the skin, assuming the nodes are clinically normal, and making sure there's not tumor in that, and sometimes it's this clear cut. You see how easy these can be to find, and we know that's the node that drained that skin. If they're node negative, that patient is still at some risk of getting recurrence because of that primary tumor being that thick and needs more close follow-up. But these are patients where these immunotherapies are now being used in, for example, some of these stage 2 tumors that are increased risk of they don't have a super high risk, but it's high enough to consider something like in pembrolizumab. We have an ongoing trial for stage 2B and 2C melanomas. So these are the ones that still aren't quite where I'm talking about neoadjuvant of the systemic up front. I'm not talking about this group either. So the slide on the left shows diffuse metastases all over the body. Now this was early on. This is right when the big articles hit. So this was Larry Flaherty's article of vemurafenib, one of the BRAF inhibitors, baseline. Look at this, day 15. Look how much of that stuff is gone. And this got everybody's attention. So I'm not talking about this group because this is not, the patients are going to be treated by systemic treatment, but it isn't as a planned before surgery approach because surgeons are not going to be part of this with rare exception, as I mentioned. Sometimes they come back and they got one lymph node, and so I am doing a surgery where I'm not. But I'm not talking about this group either. So, and these patients are best treated. These are T cells. Josh, you'd appreciate the capital T, the T cells. And you've got too many of these. The fly swatter is not hitting the one. There's too many of them for the fly swatter. I can't swing that fast and that hard. Plus, I'm going to hurt things just trying to kill them. We're not talking about that group either. We're really talking about this group where we think that my surgery is going to get it, but there are these little things that they're there. You can't see them. You can't find them on scans, but they're there. And so we end up offering treatments to patients for possibility that they're there, but not knowing what they're there. Knowing we're going to be over-treating a fair number of patients, especially with the side effects that you can get. But we really want something a little better for those patients. And for example, you might have somebody come in with a primary melanoma and it's a thick one and patient ends up getting a scan and there's a lung nodule. A lung nodule is about 5 millimeters, not big enough to really show up on a PET scan, but it's not necessarily normal. Well, maybe you want to buy some time there, maybe with something else, especially if they have positive lymph nodes, something other than going straight to surgery on that. And why not have all these T cells? I love this diagram because it's got that T cell with that arm and the clawed hand, and you can just see, I mean, that tumor cell, not only does it have to look at the one with the clawed hand, but look at all those troops around there. That tumor cell is in big trouble. Now, the patients with stage 3 melanoma, usually that's lymph nodes, and these are survival curves presented by an article by Jeff Gershenwald, who was our expert panel chair for the American Joint Committee on Cancer. And the survival curves drop, especially when you get down to the 3C and 3D category, which are based on the number of lymph nodes found, as well as the thickness and ulceration in the primary. And these are for the node-positive patients, but also for the patients who have satellite lesions. And satellites are cells that are discontinuous from the melanoma. So discontinuous, but they can be right next to it, or in transit lesions, kind of on the way to the nodes. Turns out those are bad actors, and they kind of act similar to those node-positive patients with these survival curves. So these are patients at substantial risk of having something. So if somebody comes in with enlarged lymph nodes or in transit disease, this is the population where I think it's fair game to talk about doing a systemic treatment first, especially the intransits, because my fly swatter, if I'm going after this, well, if it started on the hand and I'm treating something here, what's to say there aren't cells here or around that? We just haven't seen them yet. So these are the kind of patients I'm talking about. And so again, with breast cancer, as I mentioned, this is a woman with breast cancer in her right breast. We're looking toward her with a PET scan, and you can see on the right column those multiple lymph nodes where we can take the nodes out, but we also know there are very effective drugs that can turn those into normal, and this patient may very well be spared a complete lymph node dissection if a sentinel node turns out to be negative. And you end up with things like swollen arms. You know, if you take out groups of lymph nodes, this is a event that happens in at least 20% of patients who have a complete axillary lymph node dissection. If you add radiation on top of that, it's even higher. And this is a patient who came in, this is a CT scan with cross sections like this. So this is the pubic bone in the front. This is, we're looking from the feet. So this is the left groin area. This isn't quite the cantaloupe that I'll show you in a minute, the same patient Dr. Veach and I share, but this is about a big baseball size. Well, physically and technically, I can take that out, but is this stopping the disease in this patient? Probably a better chance that it's not than it is, and they could end up with this, a swollen leg, and if you didn't cure their cancer, that's not a very good trade-off in that. So I'm working on these two as much as you guys in the audience to just try to convince them that we need to study this as well. And you already heard, I'm just going to briefly go through this because you already have seen this. We now have the BRAF and the MEK inhibitors that are now widely used. The advantage of those, you saw that day 15 study that up there, that kind of quick response you can often have with these targeted therapies if they have the BRAF mutation. That can often be used for somebody who's got a lot of disease and really not able to take immunotherapy, or you can't wait to see if it works. You need a quick response. We've got those available. And again, some of these trials, these just came out this year, these combination trials. If you look at, I don't want you to focus too much on details, but I'll lead you to it. So the patients in the top row, the green line, the patients who had a complete response to the treatment, in this case, the combination of the BRAF and MEK inhibitors, look at their survival out at 72 months, 50%. And those curves aren't quite flattened out on the top, but if you look down overall survival, look how many patients in this, look here. You see, those are patients in there. They're all sitting in that line, and that line, you could see that line just keep going out there. So really exciting with that. And again, you heard a wonderful talk on immunotherapy. I love your slides. I think even I can understand those slides, which is a good thing. I'm not going to go through that, but we know that these combinations are now approved. We've got nivolumab is approved, ipi is approved, pembrolizumab. These are all the generic names. The trade names are the ones you see on TV because they want to promote their companies. But as we talked about, you saw, I think, this particular slide earlier, a related slide, and these curves are flat. And I love this because this is out, look at the number of months here, and you could anticipate that this is likely to continue. You're going to have some patients drop off. We certainly have patients who recur later, but we just need to be farther out. And we need to have, what we aren't seeing is the patients who would be out here. If this was 100%, we got this huge gap, and that's what Dr. Veach was talking about that is really exciting that he's working on. So how about neoadjuvant treatment? Is there any experience with that? Yes, there is. So this is a neoadjuvant, so this is before surgery in patients with resectable stage 3 melanoma. So again, these are the big lymph nodes that I would be referred to me, take the nodes out. Chance to cut, chance to cure. Take them out. We don't want to lose that chance. I'm thinking, I don't want to lose that either, but why don't we go after the disease that's life-threatening, which is not in that lymph node, it's somewhere else in the body. Again, the patients in this trial had a 49% complete pathological response. That means not only did you feel that it was gone, when you took the nodes out, there was no melanoma in there. These are big numbers. We never saw anything like this with melanoma. And another study here with IPI and Nivo. This is the immunotherapy approach. The complete pathological response in group A there with that combination, 47%. So these numbers are definitely worth thinking about. There is a neoadjuvant melanoma consortium, and we're trying to dig our way into that group to be part of that, who is really looking at this, because we really should look at it in the trial setting to make sure we're comparing apples to apples and oranges to oranges. And I'm committed to keep pushing this through, and I think my colleagues over here on the right, if I get a couple of them to join me, we'll bring the whole team into doing that. But my goal would be to, ideally, if that 47% or so turns out to be somebody we can predict, the question earlier about how do you know if you're in that group of the responder or not, I may have that not be part of my job, where I don't have to do any surgery at all on that patient. That's fine with me. Not only do they not need my surgery, but they may not have a swollen leg or a swollen arm. So now I got my patient. This is a little more detail about the one you already heard about. This, I call him my surfer dude, because this man, if he was in this room right now, you would look and say, that's your patient. He was slender, freckled, red-haired, red dreadlocks. He's a surfer dude, absolutely a surfer dude. Lives in Hawaii, actually came to Oregon to work on his brother's cannabis farm, may still be there, he may be back in Hawaii. And he comes into my clinic before Dr. Veach saw him like this, and he's got this on his back. This is the middle of his back, a big fungating, and he kind of came in because he couldn't get his arm down, and that was kind of draining and kind of smelling this thing on his back. Otherwise, he was doing okay with his cannabis farm and his brother and doing okay. So the scan, this is a similar scan, but this is, look, these are CT scans with a cross section. So it's not this way as Dr. Veach, it's this way. So looking from the feet, this is his left armpit. That's the cantaloupe. But another cut, he actually had disease in the right armpit also. So he's got the big fungating thing on the back, this arm like this, and this arm down, but with disease. But his PET scan showed nothing elsewhere in his body. So the surgery for this guy, if we do surgery up front, this is a big surgery. On his back, I have to take that off with a 2-centimeter margin, which is going to be about this big total with a skin graft. That's pretty big itself, right in the middle of the back. And bilateral complete axillary lymph node dissections. That is a huge surgery for this man. So I think I talked to Dr. Veach up front before I really pushed it on the patient, but I said, why don't we consider the systemic treatment first? I think he got IPI and Nivo combined. And in 6 months, there's nothing in his right armpit. This is his left armpit. Still something there, as you can see. His back, there's just pink skin. That raised thing's gone. So clinically, this is at least a very good partial response. So now, again, Dr. Veach sends you back and says, well, it looks good, but you still got to do surgery. And okay, well, am I going to do the same big surgery up front? Am I going to do this on his back, take out both sets of his lymph nodes? And I thought, well, let me think about this. So I did a little bit of a creative approach. What I did was, we all agreed he had something still going on in the left armpit. So I did the complete lymph node dissection. As you heard, no disease in this necrotic lymph node, all dead. I didn't do anything with his back, just we're watching that, we can see that. And I did a sentinel node biopsy, really off script, and I'll agree it was off script, to evaluate his right axillary nodes. We took several nodes out, and they're negative for melanoma. So a complete pathological response with the only surgery being the axillary dissection and the sentinel node on the side. And we're not sure if he's back in Hawaii or back on the cannabis farm right now, but this was, about a year ago, maybe a little bit longer. And I would say this is one of the best examples of really why not think about this up front going forward. So we can be chasing this train and say, some groups around the world are looking at neoadjuvant, or we can do what they do in India, and we can figure out how many people can we fit on this train. Thank you for your time. Break time? So we have a break. So we have a break right now. I think we'll hold any questions until I can answer those during the panel time, if that works for you. So take a break for 20 minutes. Come on back, and we've got 2 more very good talks, way better than ours, coming up when you come back. Okay, why don't we go ahead and get started? It's good to see all the conversations going on, because one of the things we try to promote is networking. And to see everybody talking to each other is always a great thing. So we're delighted for that. She's got the letter on. So let me introduce our next speaker. We're delighted to have one of our neighbors from the South in Portland come up to us, Dr. Anna Barr. She graciously agreed to come up. I would say enthusiastically agreed to come up to talk to our symposium. One of her colleagues, Sancy Leachman, actually came up about 5 years ago and talked at this symposium. So we're delighted. And she's going to talk about something that OHSU is calling the war on melanoma, just as a concept, but then get specifically into some head and neck melanomas and the role of Mohs surgery. Many of you may have had basal cells, or maybe you're very familiar with Mohs surgery for basal cell carcinoma. But what's the role of that in melanoma? And she trained at NYU and OHSU, and you're the co-director for dermatology surgery and the Mohs surgery and cutaneous oncology fellowship director. So we welcome you, Dr. Barr.
Thank you, everybody, for being here, and thank you to Dr. Bird for having me come up. I don't make it up to Seattle as often as I should. It's so close, I forget, but I have a lot of friends and colleagues in the Mohs surgery field here in Seattle, so I really enjoy catching up with everybody, and I really enjoyed those 2 talks. I think even as a medical professional who's in the field, there's so much new information coming to light, and I think it's so fascinating to have a forum like this where we can all keep up with it. So what I wanted to talk with you about is kind of twofold. In OHSU, we've launched a public health campaign for melanoma early detection across the state of Oregon, which I think is kind of a groundbreaking experiment, if you will. We are trying to see if public health awareness can lead to a decrease in melanoma incidence, if it can lead to more early detection. And early detection, like Dr. Bird said, is what we want. That's the time where we can cure 80% of these with surgery alone. So the more melanomas we can find in this category, the better for all of us. So how did we do that? Well, this has been the brainchild of our department chair, Dr. Sancy Leachman, who some of you may have met a few years ago. And I think this is a really brilliant ad campaign that they've put together with kind of some of these racy images to catch your attention. Oh, I got to do over here. Racy images to catch your attention, featuring people checking their skin, checking their partner's skin, and start seeing melanoma is really the message of this campaign. And there's also a website that we've started, startseeingmelanoma.com, that you can check out. And we're basically launching this. We launched it in May across the state, and we're going to be tracking their melanoma outcomes and our melanoma incidences and see if people are going to be catching their melanomas or generating public health interest in this very important topic. So mainly, we thought this would be an interesting thing to do in Oregon because Oregon has one of the highest rates. It's second only to Utah in melanoma incidence across the US. It has a very high rate of melanoma. And as we all know, and as we all have heard, that early detection saves lives. And they came up with this catchy slogan. I think this is a fabulous slogan: the cancer that you can stop with your eyes. Because if you're checking your skin, your partner's skin, and you're noticing something, and you bring it to the attention of a health professional, a family medicine doctor, internal medicine doctor, dermatologist, and that can be biopsied and taken off early, we're avoiding the problem of adjuvant therapy, chemotherapy. We're just doing a surgery, and in a lot of cases, the surgery can be fairly simple and with an 80% chance, that it's going to be cured or higher. So some of the ways that they've launched this public health campaign has been on radio ads, on billboard ads, posters in businesses. We've had digital launch on Spotify, Pandora, Oregon Live, which is our main newspaper website, in the Oregonian, in another Portland local newspaper, and all over social media. As you know, it's very popular with the younger crowd. But they've basically launched it in May across all of these different avenues. And I'm not a real specialist in Google Analytics, but there are some people in our department who are, and they have taken notes of kind of the impressions, the new website visits, and basically they've concluded that this campaign has generated over 3 million social media impressions, 2.5 million radio impressions, print impressions. The website alone has had 21,000 new users, just May through July. So we're really trying to get this message out there. And they've even ranked, locations who are using the website, with Portland, being the most visited, but also, all the way out to very rural parts of Oregon. We want to get this message across to everybody in the state. So this is Dr. Leachman, our chair, who's, I think, very brilliant idea this was to try to stop melanoma, and this is one of the ways that we can start, by making the public aware of what to look for. And if you want to join the fight, or you want to take a look at the message that we're trying to get across in Oregon, you can go to the website startseeingmelanoma.com and get a better idea of kind of the public health part of this. And with that in mind, I'm going to talk more about the early stage melanomas that, basically our colleagues covered the later stage melanomas. They've already spread. What I'm going to talk about is how do we accurately remove the early stage melanomas? How do we clear the margins so that these melanomas don't come back? How do we get rid of them the first time so you're cured of it? And my specific topic is Mohs surgery for melanoma. How many of you in the room are familiar with what Mohs surgery is? Okay, good. A good amount of you. That's great. I feel like a lot of people don't know what it means, or they think it's an acronym for something. So I'll go over what Mohs surgery is and how we're starting to use it now for margin control in melanoma. What I thought was very interesting about this topic is if you in the room, you get a basal cell carcinoma, pretty much on the face, pretty much we're treating it, almost everyone is treating it with Mohs. There are some other modalities in use, but it's very, very common to have Mohs if you have a basal cell or squamous cell carcinoma on your face. But when you get a tumor like a melanoma on your face, there is a lot of variability across the country, depending on where you are, on how you're going to get treated. And why is that? Well, let's start off with what exactly Mohs is. So Mohs surgery is named after Fred Mohs, who was a general surgeon in Wisconsin, and he invented this technique of looking at the entire margin of the tumor back in the 1930s. He developed this technique because he wanted to examine 100% of the tumor margin as it's being removed, and then if needed, you could go back to any areas that still had tumor margin present. And the main importance of this technique is that the surgeon removing the tumor is the also the pathologist that examines the tumor. It is the same person. The surgeon removes the tumor and then looks at the pathology, and then the surgeon says, hey, I didn't get it all from 12 to 3 o'clock. I got to go back to 12 to 3 o'clock. And it's a very precise removal that way because there's one person involved doing both steps. So the way that you do that is you take a disc-shaped piece of skin, and you usually cut it into a few sections. Boy, this is the weirdest pointer I ever used. Does this mouse work? No. You cut it into a few sections, and then you flatten out those sections so you can see. So actually, we flatten this out, and we slice off sections. So we are looking at the deep margin and the peripheral margin at the same time. We make frozen sections in our lab, so it takes about an hour or an hour and a half to take your tissue off your skin, freeze it, and then we make thin slices of it and stain it with different stains and put it on a microscope slide. So in that way, we're able to examine it. When Fred Mohs first developed this technique, it took overnight, and people had to stay in a hotel room in Wisconsin. He fixed it with a zinc chloride fixative paste. It took overnight to process, and then they came back in the next day. He actually didn't use any anesthesia either, so that was a pretty tough surgery for people involved. The zinc paste that he put on your face kind of numbed it a little bit, but he didn't use any anesthesia. So the process has been way refined from the 1930s, and I think it's a very good process now for a lot of skin cancers. So again, in the diagram, we see the tumor. We take a disc-shaped piece around the tumor. We try to get around it all the way on the sides and try to get it around it and the deep margin as well. And then we cut that and we look at it ourselves under the microscope. And if we need to go back, we just go back to a certain area. So we color code the tissue. I mark it red and blue and green and yellow. And if I have to go back to a certain area, maybe I just have to go back to the red side. I just go back to the red side. So in that way, we're able to get the whole tumor out, but not take out so much skin all the time. Well, that makes sense, right? Does that make sense? Why we would do a skin cancer that way? Well, why don't we use it on melanoma? Well, I'll tell you why. So melanoma is hard to see on conventional frozen sections. Here's your typical basal cell carcinoma. Some of you may have had this. It's very common. About 1 in 8 people will get this kind of skin cancer in their lives. It's very easy to see. Everyone can see these big blue balls of tumor, right? Everyone can see that. Well, look at this melanoma. This is the one that can kill you. You can hardly see it. That's the problem. And that's not all. There are other difficulties with melanoma, especially on the head and neck. So we found that facial melanomas are more likely than body melanomas to extend far beyond their clinical margins, far beyond where you can see the brown, especially on sun-damaged skin of the head and neck. So facial melanomas, when you take it off with the typical margins that Dr. Bird uses, sometimes you don't get it all, is the problem with facial melanomas. And the other problem is you don't want to take a giant margin on somebody's face because people obviously want the best cosmetic result on their face. There are other problems. This is maybe more for the, medical professionals in the room. But there are significant differences in what pathologists call melanoma in situ versus invasive melanoma. And there are problems in measuring the depth of melanoma when there's a lot of follicles involved, especially on the face. Because we have so many follicles on the face, the pathologist, if they can find a melanoma deposit that seems to be connected to the follicle, is still called in situ. If the melanoma deposit is just over here from the follicle, really close, they may measure a depth on it. However, if you cut through sections a little bit more, you may find that it actually was connected to the back of the follicle. So still in situ. This is a lot of technical problems in making the exact depth, which is very important, as you know, for treatment. There are also differences in how these melanomas on the head and neck behave. Some of them behave as aggressively as body melanomas. Some of them seem to be growing there for 10 years and not really not really doing anything. So it's possible that they have a biologic difference from some of the melanomas on the body. There are also additional difficulties when you're looking at a background of sun-damaged skin and trying to diagnose the melanoma. So melanoma is a tumor of melanocytes. There are too many melanocytes. What we found on sun-damaged skin, it already has too many weird melanocytes there. And that may be just a factor of 70, 80 years in the sun. The sun has damaged the melanocytes, making the exact margins difficult to ascertain. So there's been some new breakthroughs, though, that have helped us a lot in defining the margins and taking care of these melanomas better. And one of these breakthroughs is called immunohistochemistry. So these are immunostains that we can apply to our frozen sections that assist in the diagnosis, assist us to see the melanocytes because they bind to antigens on the melanocytes specifically. So they help us see. So this is a typical melanoma. This is a regular section, the paraffin section. This is the kind that takes overnight, and this is the standard staining. You can see there are, this is a nest of melanocytes, this big ball of melanocytes, and then there are these single melanocytes. There's way, way, way too many of them. That's abnormal. That's a melanoma, and you can see them up close. They're large cells with a clear cytoplasm. There's too many of them that shouldn't be there. There's this big collection that shouldn't be there of nests of melanocytes. In contrast, this is normal skin. And you can see the melanocytes are supposed to be one melanocyte for every 8 or 9 keratinocytes. Melanocytes are these larger cells with a clear cytoplasm. But still, I mean, that's not super obvious, I would say, for a tumor that can cause a lot of problems. And now we have this new technology called immunohistochemistry that really lights up the melanocytes for us. So this is what we used to see when we did regular stains on melanoma. Now we're doing this kind of stain. And look, I mean, I think the average person can appreciate that this is a lot easier to see these melanocytes now. So traditionally, the way that we often surgically treat melanoma is we take off the skin cancer with a margin. And the margin changes depending on the depth of the melanoma or how early it's caught. We'll use a smaller margin for early stage melanoma. For later stage melanoma, there's a bigger margin of skin involved. The thing is, though, when we take off the tumors, they're generally sent for a margin analysis where they cut through the tumor in a bunch of locations, but not every single location. So the usual way that tumors are analyzed, they're not looking at 100% of the margin like we are with Mohs. The advantage of Mohs surgery, and this is where it's tricky because it's not used everywhere for facial melanoma, but I think the advantage of Mohs surgery is that if the tumor has any tentacles, so say the tumor has a tentacle here that's extending between the different cuts that are used, this may not be caught. And this is not in every tumor, but it's sometimes. So if the tumor has some tentacles that are going outside the margin where the margins are taken, you wouldn't see it. With the Mohs surgery, we take that disc of skin and we flatten it out so we can look at the whole outside margin, 100% of it, and the whole deep margin, 100% of it. So, basically there are still a lot of questions. I mean, why aren't we using Mohs everywhere for facial melanoma? Well, I think it's still in development. There are some centers where we have it, but I would say it's a minority across the country. We're still getting a lot of data about whether it's safe, whether it's accurate. Are we, accurately interpreting this melanoma, and where do we use it? So I'll go through some of these with you. So safety-wise, there have been some good studies establishing whether Mohs for melanoma is a safe treatment. So the conventional treatment is a wide excision. With some of the studies that have been done now, they have shown that the disease-free survival for melanoma is better than when you're just randomly taking a wide excision on the face. Specifically, After 5 years, less than 3% of the patients having the Mohs surgery for melanoma had no local recurrence of the tumor, and that's compared at a recurrence rate of 5 to 15% for standard wide margin surgery on the face. Some of the data for Mohs surgery for melanoma, this is just melanoma in situ, so the earliest stage melanoma. These are mostly on the face. The recurrence rates for standard surgery, as you can see, they range from about 6 to 9 to about 20% when it's just a big wide chunk taken. But when you do the specific surgery and you trace out the margins, there are some much better recurrence rates. So, 3% or less. And at OHSU, we're in the process of publishing our data, which I'll go through with you. And we have very good recurrence rates that got even better after we started using the special immunostain to highlight the melanoma cells. And we've treated 669 melanomas, and we have an average median follow-up of 60 months. So it's one of the largest series of melanoma that is going to be published using this technique. This is one of our posters that we presented at our recent meeting, and our goal was to show our 10-year data at my institution of how we're treating these facial melanomas with the Mohs technique and show our recurrence rates. We did a very big chart review of all the ones we've done in the past 10 years. So basically, it was a retrospective review, so we looked up all of the ones in 10 years from 2007 to 2017, and in 2013, we started using this, end of 2013, 2014, we started using this immunohistochemistry technique with the special stains on the melanocytes. And basically, we're showing our technique or presenting our data on how our recurrence rates are and how we're doing with this technique. So the mean number of stages that were required to remove a melanoma is 1.6. So a lot of times we got in the first try, but a lot of times we had to go back for a second try and sometimes even a third or fourth try. Of our 668 melanomas, we had 535 that were in situ, so the very earliest stage. We had 133 that were invasive, and we had 9% that were recurrent after previous treatment elsewhere. The site, mostly were operating on the face, over 75% were on the face. On the scalp, 13%, 3% on the neck. On the body was much more rare for us to do because typically you can go see Dr. Bird and have a wide margin taken, but occasionally when that wide margin wasn't enough, then they would get referred to us for additional margin checking. Of these melanomas, about 30% up we would stitch up the same day, and the other times we would take a very small final margin for permanent pathologic analysis with the paraffin sections to kind of double check our work / make sure the melanoma hasn't spread outside this specific area, and they were stitched up usually the next day. Our cohort of melanomas, it seems like we're getting the more difficult melanomas in the state now because kind of the word is getting out there that we're doing these melanomas with the Mohs. So we are getting more melanomas that failed treatment with another modality, and we're just getting more difficult melanomas because we're a tertiary referral center. But even though we're getting those difficult cases, we still have, with our MART1 group, we still have a very low recurrence rate, 0.4%, even improving on our prior recurrence rate of 3% since we've been using the special staining technique. So again, with these early melanomas, the recurrence-free survival is very, very good. It's upwards of 96%. And of course, there were some deaths in our group, unfortunately, from melanoma, but we were not usually able to link them to the facial melanoma. It was usually a separate kind of body melanoma that had caught, a separate site that they had that caused the death. But Fortunately, the death rate was very, very low. So this is some of our kind of numbers, and you could see that most of the tumors that we treated, most of them were in situ, and then we did have some deeper tumors that we treated because they were not able to get the margins clear with the usual surgery. And some of the patients that had recurrences, I couldn't really see much of a pattern here. It seemed like all areas across the face, but fortunately for these 12 or 13 patients, it wasn't very many that had recurred. Out of the recurrences, I wouldn't say there's any particular pattern, but we're still tracking all of this data for our patients. So another thing to know, and another reason we're using it is because, as I mentioned, there's something strange about these facial melanomas. They often have this subclinical spread, means it goes beyond where that brown spot stops. And we don't know why they behave this way, but there have been many studies showing that oftentimes you need a bigger margin than you think, 9 millimeters, this 22% required greater than 5 millimeters, 8 millimeters, to achieve 95% clearance, this is 6 to 9 millimeters. So the actual margins on the facial melanoma are a little bit unclear. The reason that we're doing it with the Mohs technique is because when you take that standard recommended margin, you might not get it all. And from the dermatology surgery literature, the margin size is ranging from 7.2 millimeters on the face to, if it's a recurrent melanoma on your face, 9.6 millimeters. So, nobody really knows the exact margin to take. That's why I think it's useful to have this technique available. If you don't know which margin to take, you start off with like a 5 millimeter margin, you check that. If that didn't get it all, you can take another 2 millimeters just in the place where you had a little more melanoma, and then you take a couple more millimeters and check. And it can be a long day, it can be a tedious day. Patients are there for an hour and a half with every check, so it can be a long day, but I think it can be worth it in the end, specifically for some of these difficult facial melanomas. And the 5-year survival rates, as compared with excisional surgery, the standard wide excision on the face, the survival rates are, this is with Mohs, and this is with standard surgery. This is for early melanomas, and this is, at all stages of melanomas. The survival rates are at least similar to better with the Mohs surgery with the margin control. So I'll show you some cases from my practice. And, a lot of these, I give talks about reconstruction, so a lot of these are kind of, big defects on the face that we've had to do reconstructive surgery, but, I hope it's not, something that's scary to look at, because I think that it's very uplifting to see how good the results can be. Even if you have a facial melanoma or a melanoma in a sensitive area, how refined the reconstructive techniques have gotten, how good you can look afterwards. I think there's a lot of hope, even if you have to have a melanoma on your face surgically removed, with some of our techniques. And then we have lasers that we can treat the scar. I think that a lot of times everything can still look really, really good in a lot of cases. So this is one interesting kind of technique I like to show, a lot to the doctors out there, but that we have this UV lamp that we use to look at the melanoma borders, because I think sometimes melanoma on the face can be not super obvious, but this is a large recurrent melanoma. And when you're looking at her, I don't think that this is kind of not super obvious. It's very light brown. It's not like that black brown that Dr. Bird showed. It's not like that huge nodule. It's like kind of subtle. When you look at it under this UV lamp, you can kind of see a little bit better the extent of where these melanocytes are. One of the places where this is useful is an amelanotic melanoma. This is a kind of melanoma that doesn't have a lot of pigment, and it can be pink. It's kind of scary, it's not even brown. It's hard to I don't know, it's like a scary thing. You think melanoma, you got to look for something black and brown on your skin, and it doesn't always show up that way. So this lady had an amelanotic melanoma, but as you can see, I don't think it was too clinically obvious, but when I looked under the microscope, it was pretty obvious. It was definitely there. So I took some, but then I had to take about this much to get it clear. I stitched her up with this is a full thickness skin graft right here in the center, but most of it is just closed in a fine straight line. And there she is at a month, healing up pretty well. Here's another difficult melanoma that I treated. He actually had two that were kind of like side by side, but I discovered in the removing of them that it was actually just one lesion. So he's a very fair-skinned guy. His melanoma is not very dark, and it's very difficult to know exactly where to cut. Well, there he is with his final defect. I reconstructed this with an advancement flap and a full-thickness skin graft, and that's how he healed at a month. This is what it looked like under the microscope for me. This is his center of his tumor, and that was my first Mohs stage. When I saw this, I knew that I had to go back and get a little bit more because there were way, way, way too many melanocytes that shouldn't be there. But by the third try, look how much better that looks, and then I knew I had gotten it all. And there he is at a couple months follow-up, healing very nicely. It's useful, in all ages. Sometimes young patients can have melanoma. This guy was only in his early 40s. The melanoma was not very obvious. As you can see, I didn't even know where exactly to start is my circles. I started just right around the biopsy site. And here he is at his first Mohs stage. And I knew when I saw this that I knew that I didn't get it all. But I kept going until I had finally gotten it all and reconstructed with this advancement flap. And here he is at 1 month, healing up nicely. It's useful in recurrent melanomas. This was a tricky case. This was a melanoma on his lip that I treated. It had recurred after 17 years. And you can see it better under the black light. But I mean, it's pretty hard to see just with your eye. So I took it off. This was his defect after he was clear. I reconstructed this with a bilateral advancement flap and a small skin graft. So I cut all the way out to here, and I cut all the way out to here, and I cut around this nostril, and I brought all the skin together. And for the underside of his nose, I used a real small skin graft right there. That's how he was healing at suture removal, at 1 month, 2 months. Now, there he is now, a few months out. Looks pretty normal. He was happy. Good smile, he could talk, he could eat. The nose is a really common location for me. Here's a small melanoma. I was able to get it clear by the first stage. It had a little bit of melanoma there, but by the second try I got it clear and reconstructed it there with a skin graft. The skin graft at 1 week, it actually wasn't getting as much blood supply as I like to see in a skin graft. So, but with some good wound care, she sent me a selfie. She was very happy, and she was pleased with that final result. Here's another, this was a recurrent melanoma on a lady's nostril. She was a younger lady in her 40s. And this is one of the reconstructive surgeries that I give some talks about, like the technical details of how to do it. But this is a type of surgery where you can make a new nose for somebody using their forehead skin, but you have to leave it attached for about 2-3 weeks to get its new blood supply. So I did that for her because enough of her nostril was gone that there was no way to do a skin graft. It was like too thick and too much of it was gone, and the skin graft wouldn't have looked normal. So there she is at 1 month after the surgery. And this is not a surgery I invented. This surgery has been going on for thousands of years since the ancient Hindus were using it for people who lost their noses from leprosy. So it's not my invention, but it's a very good surgery. And there she is at 3 months, and I did a little scar revision for her eyebrow and her lip. And then she sent me a selfie, and she was very happy with that final result. Again, a couple more with this surgery. Kind of a big defect, a lot of his cheek, a lot of his nose. And at the time he was in his 80s, but very healthy otherwise. And besides this flap looking kind of awful for 3 weeks, it's not, it's not something that you can't recover from. It's the first 3 weeks are definitely rough, but after about 5 months, you're starting to look like, kind of a normal nose and a normal person. Here's another example of melanoma on the nasal tip. Just nose happens to be a very common location for these. And doing the same kind of surgery, the same forehead flap, leaving this skin, we leave the skin attached there for 2 to 3 weeks. And then we take down the attachment. And there he is about a year later. It's like a very good cosmetic result. So I've done a lot of these for the melanomas on the nose. They heal up very nicely. And I have tons of examples of melanomas, and we generally get the bigger ones at my institution. If you have a real small one, you may not be sent, to somebody like me. But some of the bigger ones is basically what we specialize in here. And there he is a few years later. I happened just to see him for something else with very little sign that a melanoma had even been there. So even some of these big defects, we're using these advanced reconstructive techniques and flaps and restoring people's cosmetic appearance after their melanoma surgery. We were able to take off the appropriate margin, check the margin, make sure we got it all, and then immediately afterwards do the reconstruction so that people can resume a normal life with relatively as minimal scarring, make it as minimal as we possibly can. This is my last case here. This was a real interesting location on the chin. I don't see too many on the chin. I designed this new flap that was called a bilateral island pedicle flap. We're writing this one up now because it's kind of was a new idea at the time. And I took these 2 islands of skin and I left them all attached at the deep margin. I left it all attached, so it wasn't like a graft. It was still attached to the blood supply. And I moved that together as close as I could. There was one small area I couldn't quite get them all the way together, so I used a small skin graft from the neck. I figured people want a little neck lift anyway, so. And there he is at a couple months, healing up very nicely. Head on, it's real hard to tell that he had anything done. So thank you so much for your attention. I appreciate you having me here.
I think we'll hold questions for now to the panel session if we could. And we thought this talk with another one without the pictures before lunch was probably a good intermediate. Getting a lot of head nods on that. Thank you so much, Dr. Barr. That was quite interesting. We have one more talk before lunch, and I didn't bring my intro up, but I've got, So Lauren Fascini is going to be talking. We haven't had this topic at this symposium, I don't think, before, which is talking about the genetics of cancer in general and melanoma in specific. But I think the important thing is to know this as a resource is huge. And I think a lot of people are confused about what is out there and whether they should undergo any kind of genetic testing. And I think you're going to hear a little bit about the difference between genetic counseling and genetic testing, which are very different. So if a provider of yours just says, I'm going to run a blood test on you on this, go, whoa, I want to see a genetic counselor first. That's my take home from this. But Lauren Fascini is one of our genetic counselors at the SCCA. I get to work alongside these incredible clinicians, and she's going to give a wonderful presentation, I think, that's very informative, and try to pull what we know about melanoma into that as well. So, Lauren, thank you for coming.
I've never used one of these before.
And then just pop it.
Okay, perfect. And then the little clicker.
Yeah, so advance forward. That's the pointer that points here.
Perfect.
It shows up there, too.
Okay, great. All right, well, thank you so much to Dr. Bird and the Melanoma Research Foundation for having me. Again, my name is Lauren, and I'm a genetic counselor here at SCCA, so I hope to share a little bit about the hereditary nature of melanoma, which is a very new and emerging field, well, genetics in general is, in medicine. So I'll talk to you a little bit about that. I also just want to say that, melanoma is a topic that's near and dear to my own heart because I was a caretaker for a very close relative with melanoma for many years. So very excited to be here, very thankful for all of you here in the audience and all the caretakers.
Can everyone hear okay?
Can you hear me okay? Okay. All right. So today we're going to do a little Cancer Genetics 101, just kind of reviewing the basics. We'll also talk about hereditary melanoma specifically. We'll then talk about genetic testing and genetic counseling. Again, what are those differences and what are those things? We'll then talk about the pros and cons of genetic testing. We'll run through an example case for you guys. And then we'll end on a note on direct-to-consumer genetic testing, which is always a very hot topic. Okay, so let's jump back, and I'm gonna, take you back to your high school biology course. And we're gonna talk about, genetics 101. So in our body, we have cells. We are made up of billions and billions of cells, and those are all different. But what's similar about them is within each cell, you have your DNA. Now, your DNA is a molecule. It's an instruction manual for your body, and it's organized onto these chromosomes right here. And these chromosomes, you have 23 pairs of them, one set from mom and one set from dad. And again, they hold your DNA. They're the instruction manual for your body. Now, when we're talking about genes, a gene is a very particular segment of your DNA. So it's a small piece of your DNA that's very specific instruction for your body. It tells your body essentially how to make a specific protein, and then that protein goes and does what it's supposed to do in your body. So when we think about genes, you have over 20,000 of these genes that are active in your body across all of those 23 pairs of chromosomes. So lots of them. We're not going to talk about all 20,000, obviously, but we'll talk about the ones that are important. Okay, so what are genetic mutations? You've kind of heard this thrown around a lot, but I think it's good just to jump back and say, okay, hold on, what is a genetic mutation? Well, a genetic mutation is a change in the DNA itself, usually within that gene. And we kind of refer to these as a spelling change. So if we think of your DNA as an instruction manual, well, then a genetic change is a spelling change in one of those words. So it can be, something that's shown here. So we see like a direct letter change from a T to a C, or it could be that there's actually missing or added parts to that gene. So a missing or added parts of or words to your instruction manual. Okay. Now we all have genetic mutations in our body. So genetic mutations, cause genetic variation. They cause me to be me and you guys to be you. And usually they're harmless. Usually they don't do anything wrong. They're just a part of normal genetic variation. But occasionally, genetic mutations can be harmful for a gene in that it changes the instruction manual so that it can't be read by the body properly. And when that happens, you can have genes that aren't, working properly in the body. So, their proteins that they're supposed to be making are either not working right or they're totally missing altogether from the body. Okay. So I want to introduce a phrase to you that you may have heard before, but was introduced to me in grad school, and that is that all cancer is genetic, but not all cancer is inherited. So I'm going to split up that phrase into two different slides. We're going to start with all cancer is genetic. So what does that mean? Well, as you've heard prior to this, a cancer is essentially a disease that arises when there are so many genetic mutations in the DNA that it causes the cells not to work properly, instead of this normal process here, where we see a cell with damage then goes to apoptosis or cell suicide and kind of takes care of itself. With cancer, that mutation, the cell doesn't take care of itself. We have multiple mutations typically within a cancer, and then that can lead to uncontrolled cell growth. Okay, and that's what we're talking about with a lot of these genetic mutations. So that second half of the phrase, so all cancer is genetic, but not all cancer is inherited. So what are we talking about with that? Well, we're talking about the fact that those mutations that cause cancer actually fall into one of two categories, okay? So the first category they can fall into is what we call somatic mutations. These are acquired mutations. So these are mutations that happen later on in life. So after your birth, either from sun exposure, just errors in replication as your body's growing older, et cetera. And typically when we think about these mutations, they're really just in the tumor tissue. So if we look at this little picture up here, it's just in one part of the body, and it's not throughout the other healthy cells. Okay, so something that can't be passed on arose in the tumor due to outside factors. Now, the other category is a germline mutation. So a germline mutation is a genetic mutation that was inherited from one of your parents. That's something you were born with. It was a change in the sperm and egg, and it's therefore in every single cell of your body. Okay. This is also known as a hereditary cancer syndrome. And as a genetic counselor, these are the mutations that I'm really focused on, okay? So when we're talking about genetic mutations for this lecture, we're gonna be thinking about those germline ones, those ones that you could have inherited from your parents that put you at increased risk to get cancer in your lifetime and then could have been passed on, okay? All right, so genetic testing. So what are genetic tests? Well, genetic tests can help us identify genetic mutations in your DNA. That's kind of the role of them. And just like we have two categories of genetic mutations, we have two categories of genetic testing. So the first is that tumor or somatic testing. So that's just testing the tumor cells to look at those mutations. Those can help us understand the nature of the tumor and also what treatments possibly could work. We heard a lot about that in this morning. Those can be very, very helpful for treatment purposes. And then the other form of genetic testing is, looking at the cells you were born with. That's typically either your blood or saliva. And we're saying, okay, can, this type of genetic testing help us understand if the person has an inherited genetic change that put them at increased risk to get this particular cancer? And so again, today this is what I'm focusing on, this germline testing. So not the tumor testing, but the germline. Was there something inherited that we can test for? Okay, so let's transition and talk a little bit about hereditary melanoma. What does that look like? I draw this pie chart out for all of my patients when they come in and talk to me, just so that they can visualize, essentially how rare these conditions are. So 90% of melanoma cases are what we call sporadic, meaning they happened essentially by chance. It could be due to sun exposure. It could be due just to an error in replication. It's probably due to a multitude of many different things that we can't really pin down. But for the most part, melanoma, just happens for unknown reasons in 90% of those cases. Another category that melanoma can fall into is familial melanoma. And that's only 10% of melanoma cases. So what I mean by that is, this individual who has melanoma also has close relatives who also have melanoma. So typically we're seeing at least 2 or 3 cases of melanoma within a close family. All right. Now, if we think about that 10%, this is the group that we're more concerned with because we're seeing possibly a hereditary factor. And we do testing on some of these families and we find out that of this 10% category that they have a familial melanoma, about half of them, so 45 to 50% of those people will actually test positive. So if we do a genetic test, we're looking for an inherited cause. About half of them have a genetic cause that could explain their own history of melanoma and possibly their families. Okay. So features of melanoma. So how I like to describe this as, I'm essentially looking for clues or red flags in someone's personal history and their family's history that make me more suspicious that they fall into that very small sliver of the pie rather than anyone else. So things I look for, first and foremost, young age diagnosis. I'm more concerned with cancers in general that are under 50 than those that are over 50 because we know a huge risk factor for cancer in general is age. The second thing I'm looking at is, do I see individuals with multiple cancer diagnoses? So, do they either have multiple melanoma primary cancers or do they have a history of melanoma and breast cancer? So something that's just a little bit more unusual. And then kind of going on with that trend, I'm looking to see if multiple family members were affected with cancers. As we look at the generations, we're going to look at siblings, children, parents, aunts, uncles, cousins, grandparents, and sometimes even further than that. How many people am I seeing with cancer, and is it more than you typically expect to see? And then right along with that, when I'm looking at those relatives, I'm looking at what type of cancers they were. So are they rare cancers where they're so unusual that they have a high chance to be genetic, or related, meaning when we see them in a tree, we're suspicious of a hereditary cancer syndrome. So either lots of melanomas altogether, or a melanoma and a pancreatic cancer, which can sometimes run together. And I'll talk a little bit more about that later. And then other things I'm looking for are other clinical features suggestive of a particular condition. So some of these inherited conditions have other features to them outside of cancer that can give us clues that there might be something hereditary going on. And then suggestive tumor studies. So we think about that tumor testing I told you we weren't going to talk about, but this is the one exception. Sometimes when we do tumor testing, when we look at the cancer, we see a genetic mutation, and we're actually suspicious that that mutation is throughout the entire person, not just in the tumor, in which case, their physician may refer to someone like me to do that germline testing to see if it is indeed throughout the rest of their body. Okay, so let's talk a little bit more about these specific hereditary melanoma conditions. And I do want to say this is an evolving area. We've only recently been studying hereditary melanoma because we said, oh, that's due to the sun, it's not hereditary, but in fact, we're learning that it is. So the first one I want to talk to you about are the genes CDKN2A and CDK4. These genes are kind of the most well-known, and in fact, they're the most common mutations we see with hereditary melanoma. And if you have a germline mutation in one of these genes, then you have a condition called familial atypical multiple melanoma syndrome, or FAM. So for individuals who come back positive and they have this, we're saying, okay, this may explain their history of melanoma, and what other cancers are they at risk for? And we know that individuals who have these germline mutations are also at risk for pancreatic cancer, so that's something we're thinking about for them. Other familial melanoma genes include BAP1, MIF, and POT1. So these are relatively newer genes that we've just learned about and can have kind of present with hereditary melanoma. And then the last category are other genes with an increased risk for melanoma, but often melanoma isn't that presenting cancer. So they're not coming in because of all this melanoma we're seeing in the family. And those genes, I think the two more well-known ones are BRCA1 and BRCA2, which are the two most common causes of hereditary breast and ovarian cancer. You've kind of heard of them referenced as BRCA. And essentially we know, especially with BRCA2, that those individuals do have an increased risk for melanoma in addition to those other cancers. But typically when we're looking at those family histories, it's not melanoma we're seeing, it's more the breast, the ovarian, prostate. But we do know there's an increased risk. Okay, so let's say you go to your doctor, you get a referral to a genetic counselor, that your family history and your own history is suspicious, and we decide to do some genetic testing. Part of that conversation is really going to be discussing what are the pros and cons of testing. How can this benefit me and how can this potentially not be helpful at all? So let's start with the benefits. I think a big benefit for some people is to provide an explanation for the cancer history. A lot of the times a big question that patients walk in is why is this happening to me? Why me? Why now? Or why all these people in my family? And so I think even just being able to understand why that's happening or rule out some of those hereditary conditions can be helpful. Secondly is, as I've kind of alluded to, if we have the knowledge that you do carry one of these germline mutations, we can say, okay, we know it's at risk for melanoma, but what other things are you possibly at risk for? Very rarely are these, germline mutations just putting you at risk for one cancer, but there might be others. So we're saying, okay, if you're positive, what other cancers are there that you're at risk for? And how should we be following you differently because of those risks? Or should we be following you a little closer with additional screenings? Should we be thinking about doing some proactive methods? So that's a part of the conversation. And then, I think this is a huge driving factor for a lot of my patients, is it can provide a risk information for family members. So they're saying, you know what, I see all this cancer in my family, I'm scared for my children. If we can figure out what's going on, then we can test them directly for that change and we can know what their risks are. And that can be especially helpful, when these families test positive, we can test them directly for that change. We say you have it or you don't, and then we can follow you appropriately. So what cancers are you at risk for? Should we be following you any closer than we are now? And then lastly, genetic test results may actually help guide treatment. So this is a very new field, but we're starting to learn that with certain genetic mutations, certain therapies work better than others. And so, does this give us any information that may impact your treatment? A lot of this is research, a lot of this is not first line. So certainly, things that I don't want you guys to focus on, but there's the potential for it. Okay, what are those drawbacks? So we've talked a lot about the benefits. Some people feel like I'm a salesman saying everyone should get genetic testing, but there are some drawbacks. And things that my patients really have to think of. The first is a negative result doesn't eliminate your risk. And I can't stress this enough. So if we think back to our pie chart, those familial cases, that 10% category, only half of them can we explain. Okay, only half of them can we give information for. That other half is still unexplained. And I can't remove that family history from a person with a negative genetic test. I can say, okay, it's really great that you don't have these things, but at the same time, you're still at risk. You still need to get your skin checks. We're still going to be following you closely because of this history. Secondly, more information isn't always useful. Some people don't want to know if they are at increased risk for other cancers. They're saying, you know what, if I have a 10% X, Y, and Z risk of this, I don't want to know that. That's just going to keep me up at night. That's just going to cause me anxiety. I don't want to know. And then also there's the potential for uncertain results. That uncertainty can kind of come in two forms. So the first is, like I've said many times, genetic testing is new. It's a new field. We don't know everything there is to know about all those genes and what their risks are. So if you come back positive, we may only have partial information for you. We may be telling you, okay, continue to check in every year with genetics to see if there's any recommendations for you, because at this time we just don't know. And then the second form of uncertainty can actually come in the result itself. We talk a lot about if you're positive or if you're negative, but there's actually a third result, and that's uncertain. And that essentially means we see a genetic change in one of your genes, but we're not sure if that's harmful to the gene, if it's actually a cancer-causing mutation, or is it just normal genetic variation? Is the part of genetic variation that makes me and you? And in which case, it just can be a little bit stressful for patients. But my job is to talk to you about that uncertain variant, if we're suspicious of it, if we're not, and likely those won't change your care at all. And then lastly is the fear of genetic discrimination. A lot of people are saying, okay, I'm giving you the instruction manual to my body. Does this actually put me at risk for any form of discrimination, either from my health insurance company or my employment, anything? And I do want to talk a little bit more about that. So when it comes to genetic testing, you're actually more protected than you think when it comes to clinical tests. So there is a law called GINA, the Genetic Information Non-Discrimination Act. It was passed in 2008, and that law is a federal law, and it says that health insurance companies and places of employment cannot use your genetic test results for coverage or rates. Okay, so you are protected by that law, and your results, if they're clinical, are also protected by HIPAA. Okay, so these cannot be used against you. Like most laws, people have found exceptions to them. The first is for federal healthcare services, so people who are covered by TRICARE, the VA, Indian Health Services. GINA actually doesn't apply to them. Another type of insurance that isn't under that GINA law is life insurance, long-term care insurance, and disability insurance. So, if you are applying for life insurance, how I like to describe it is a life insurance company could technically ask you, have you ever had genetic testing? And legally, you would be obligated to tell them of your genetic test results. Now, if you already have life insurance in place, you don't really have to think about that. If you've already had a cancer diagnosis, that typically holds a little bit more weight than a genetic one. But it's more things we're thinking about for family members who are unaffected with cancer and who are thinking about, doing genetic testing at a young age where they may not have these policies already in place. Okay. So genetic counseling, what is genetic counseling? So by definition, genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. That is a mouthful. But really, any healthcare provider who is well-trained in the genetics area, is up to date, can provide genetic counseling for you. And that process typically involves, describing. So genetic education, kind of like what we've done already, inheritance patterns, possible results, the pros and cons of the testing. Also reviewing your personal family and your family's history, so taking what we call a pedigree or a family tree to look out at those generations. And then assessing. So what are your attitudes towards genetic testing? What are your concerns regarding privacy, results, et cetera? And how will these results actually be implemented or utilized in your care? Is this actually going to do anything that's beneficial? And so like I said, any provider can do genetic counseling as long as they're up to date and kind of going through this process. But as a genetic counselor, this is my specialty. So genetic counselors are healthcare professionals who are trained equally in genetics and counseling to help patients, their families, and other providers navigate the world of genetics and genetic testing. There's a lot of test options out there for providers, and they don't have, in the span of a 60 or 30 or half an hour, 15-minute appointment to talk to you about all of these things. And so that's when they kind of outsource to us so we can have that conversation. We can talk to you about your family history in depth. We can review, your insurance coverage, what your out-of-pocket is going to be, et cetera. And then we also provide education to providers because there's a shortage of us. I will just say that. We're not all over Washington in every healthcare system, but we do outsource. We educate other providers about how to go about ordering genetic testing, what to look for, so that we can expand our services. Okay, so let's review an example case, just kind of something I do in clinic typically. So a 32-year-old woman is referred to me because she has had 3 primary cutaneous malignant melanomas. We take a family history, so this is a pedigree, which is what it kind of looks like in clinic. And what we see is that it's notable for 5 total melanomas at young ages and 1 pancreatic cancer case. So circles are women, squares are men. But if we kind of look, there it is. So this is our patient. Here's her melanoma history. She had 1 at 27, 1 at 30, 1 at 31. It was also noted that she has over 200 moles throughout her body. Some of those are pretty atypical. She has a couple siblings. She has a 28-year-old sister right here who's healthy. And then she has a 25-year-old brother who was recently diagnosed with 2 primary melanomas about a year ago, and he also has a lot of moles. If we go up to their family history, so we go up, there's our father. He's alive and doing well. Grandparents lived to older ages and just kind of died of age-related factors, all pretty healthy on dad's side. But we go to mom's side and we see that mom actually passed away quite young of pancreatic cancer at 63. And so, for this is a little bit of a red flag for us because pancreatic cancer is one of those related cancers to melanoma when it's due to a hereditary cause. And then, we look at the other relatives in the family, not too much here, but we do see that the grandfather died young and had a history of skin cancer. So we talk to our patient and we say, okay, do you want to do some genetic testing? And she says, yes. And turns out she's positive. So she has a pathogenic mutation in CDKN2A, which gives her the clinical diagnosis of familial atypical multiple mole melanoma syndrome. And so with this, we know she's already had melanoma, but people with this condition are at increased risk for melanoma and also increased risk for pancreatic cancer. Like I said, these things are relatively new, and that risk for pancreatic cancer is a little bit hazy. Right now, we think it's around 17%, but I've seen it quoted as high as 58%, which is significant. So our next steps, we're gonna make sure she's going to derm. She should be already, she's had 3 melanomas. But make sure she's following up with dermatology and make sure that we send her to GI as well. Typically we wanna send her to a specialist who does pancreatic cancer screening specifically, which is a little bit of a debated screening, but possible. We do it here at SCCA. And then we're also gonna recommend testing for her family. All right, she's tested positive, we know she has it. Therefore, she probably got it from one of her parents, most likely mom, given the history, and we know it's related pancreatic cancer. But we'll test dad to make sure that it indeed came from mom's side of the family. And then we'll test each of her siblings. I'm pretty positive that brother's gonna be positive, but you never know. We wanna test to make sure. And especially test the sister too, because she's 28 and healthy, but that doesn't mean that she doesn't harbor that mutation, and she just, hasn't developed cancer. Okay, So I want to talk to you a little bit about direct-to-consumer genetic testing, and what I mean by these things are like 23andMe, Ancestry.com. Right now you can't walk through Target without being bombarded with sales on these things. Just send in your saliva. I've even seen tests that tell you they can tell you your wine preferences, etc. Anyways. So direct-to-consumer tests are great for people who are interested in their ancestry, fun facts, etc. How much Neanderthal do I have in me? I have to know. It's great for these people. You know, I call it recreational genetics. You want to know these things? If you find them, you know, interesting, great. However, these are not clinical tests. They should not be used for health information at all, and I want to be very explicitly clear about that. You know, and what it comes down to is these laboratories are not looking at all of those genes that I have just talked to you about, and especially they're not looking them at the even if they say they're looking at them, they're not looking at them at the closest detail that we are. Okay. And I also want you to be very cautious of third-party sites that offer to analyze your raw data for a very small fee. So what they say, things like Prometheus, if you've heard of them, they will say for $10, get your raw data, send it to us, and we'll tell you what all those other genetic factors that they didn't tell you about mean. Okay, well, a recent study came out and showed that 40% of those results were actually false positives. So if you get your raw data from like an Ancestry.com, pop it through a site that promises to analyze it and look at all those hidden changes, it is probably very likely that they are not accurate. Either they're false positives or false negatives. They're not picking up on things. Okay. You know, I like to include this slide because I think it really summarizes, you know, my perspective. You know, your DNA is not your destiny as much as people like to say it is. And, you know, I am doomed because it's in my genes. I inherited this from my mom, therefore I will get it. It's not necessarily true. You know, DNA is not destiny, it's just a very useful tool, and I think that's very important to remember. There are many other factors to your health that you can control that do impact your risk of cancer more than your genetics. We're thinking of, you know, sun protection, you know, living a healthy lifestyle, also just managing your care based on your family history, regardless of your test results. So certainly, DNA is not destiny, and you're hearing that from a genetic counselor. Okay, so just to kind of summarize my talk for you guys, hereditary cancer syndromes are very rare. Remember, 5% maybe of melanoma cases. But knowledge of one of these can be helpful for you and your family, absolutely. So genetic counseling can help determine if genetic testing is right for you and what your results mean for both you and your family. And then lastly, if you're interested in genetic testing, clinical tests provide much more information than direct-to-consumer testing. Okay? All right.
Outstanding talk. I would ask our morning speakers to come on up to the chairs here. I think Dr. Barr is just getting a drink of water. She's not running away. You want a drink of water too? Great. So we've got about 15 minutes before our lunch break. I think you can see why we got these speakers this morning to come talk to you, because I learned a ton and I thought I know a little bit about some of this stuff. So let's go ahead. No, we got Dr. Veach. Why don't we start with Dr. Veach is right here. Yes, now we use, there are microphones that are around it. Have anybody seen this microphone before?
It's soft.
Some places throw this microphone because it's very soft. Let's pass it, but it's a good microphone to use. Yes, sir.
A question for you, Dr. Bird.
Okay.
These days, when you're confronted with a patient with a really nasty primary high-risk cutaneous melanoma, let's say a young adult or a middle-aged adult, and their sentinel lymph node is biopsy negative, and they have no clinical evidence of metastatic disease, but based on the primary, you know they're at high risk of metastatic complications. How tempted are you now to look at prophylactic use of interventions to systemic therapy?
Yeah, I try to take temptation and put science and evidence-based medicine in front of them temptation, because I find you don't want to go the other way around. As I mentioned earlier, we do get some concern. For example, that 3.4 millimeter thick melanoma that was ulcerated, even if that sentinel node is negative, that patient has a recurrence, probably in the order of about 15 to 20%, which is not small. We actually have a trial, which is a national trial on comparing pembrolizumab, one of the immunotherapy drugs, versus placebo for that patient population. And so we definitely think about that. Now that is actually a very hard trial to accrue patients to, because you're either a believer that this is going to help, therefore you don't want the placebo, or you don't want the side effects of this immunotherapy, and you know you got an 80% chance of not getting it. So we're trying to figure out how to do those types of trials, but I wouldn't recommend doing that off a trial basis, because we really don't know. And as you heard, you saw the list, the side effects of the immunotherapy can be substantial. Maybe I'll ask Dr. Veach to comment on if I send one to him, or he accidentally runs into somebody, let's say even a 2B or a 2A, how do you address that, Josh?
Well, do I have to press something here?
Maybe. Tap it on top. Yeah, it's on.
Yeah, I guess it's on. Yeah, so we do have a clinical trial for stage 2B and 2C. And in the case of 2C, the recurrence risk is greater than it is for 3A, even though it's 2 rather than 3. And so for people with 2C, we definitely strongly encourage people enroll in that trial so that we can sort of we can help them and also get evidence that will allow us to sort of treat patients with lower stage disease in the future. I think with stage 2A, I don't think they're eligible, but I think for 2C, I would sort of strongly recommend going on the trial, and for 2B, it would be a longer discussion about the pros and cons. I mean, I think with the immunotherapy treatments, the way I think about the side effects is that most people do fine. There's a chunk of people, maybe a quarter, that have major problems that can be dealt with but cause issues. And then there's a small sliver of people that can have very, very severe problems, and it's an individual choice about sort of taking those risks on for what might be an absolute risk reduction of a long-term bad outcome of melanoma of maybe 10%.
But there are
20%.
But there are stop points if patients are in that quarter group where they don't have to commit to the entire trial of that treatment if they have systemic
Yeah, of course.
side
If
effects.
somebody has problems, we deal with them as they come. And
Great question.
Yeah, I have a question for Lauren. Lauren, I was wondering if insurance ever covers the cost of genetic testing. And I have a second question too. Also, at what point during the course you recommend someone to do it if they are, or is just sooner better?
Okay, great questions. For the insurance coverage, yes and no. I was debating about including a slide in this, but essentially, genetic testing is covered by a lot of insurance companies. However, they typically cover it for more common or well-established cancers such as breast cancer, ovarian cancer. Melanoma is a little iffy. Sometimes I do get pretty good coverage from insurance companies and sometimes not. It really is dependent. But part of my job is looking at your insurance and saying, okay, does it cover testing? If it doesn't, there are some less expensive options out there. I can usually, if people are paying out of pocket, it's about $250 is the maximum that patients pay, which for, it's $250, so it's expensive, but certainly that's pretty doable compared to what it used to cost, which is thousands. And then secondly, at what point in the process should you do genetic counseling or genetic testing? Really at any point where you feel like that information is going to be most helpful for you. I think if, so let's say in the breast world, we often do it pretty upfront because sometimes that can have surgical management changes. But with a lot of these other cancers like melanoma, it's not going to likely change your care immediately. So certainly whenever it makes sense to you, whenever you're less stressed, but it's still on your mind, please don't wait 50 years and come back and see me. But, really, there's not a huge time constraint either beginning and whenever feels right to you.
Okay, we got lots of questions. I'm going to try to do some crowd control. Microphone there, Monica, and here for the next three. Not forgetting the rest of you.
Yeah, a question for Dr. Barr. Does the MART1 staining distinguish between malignant melanoma cells and normal melanocytes?
Not really. But there are other things that you look at with the stain. So there's supposed to be the right number of melanocytes in a certain area. Even all Caucasian people, all African American people, we're supposed to have the same number of melanocytes in our skin. And the problem, melanoma, forms when there are too many. They start multiplying, they start increasing. So with the MART1, we can see where they're increased and they're not supposed to be, but we can't see the actual morphology of the cells with the MART1 stain. But that's why there are other paraffin, if we do our standard paraffin section on the melanoma, which is why we take our final margin of like 1 millimeter around what we think is clear, and we send that for the paraffin sections, then we can really look to make sure that there are no atypical melanocytes, because that's what they can see on the overnight testing, even better than what we can see on the frozen.
Okay. Here, and other. Next one's going to be back there.
So I have two questions. My first one is for you, Dr. Barr. How do you tell the difference between a facial melanoma, since some of them are so light colored, versus something else? And then my other question is for Lauren. What clinical features do you look at that are, maybe you already answered this, that are risk factors for melanoma that maybe weren't in there? I don't even know what those are.
Yeah, so I'll start real quick. So
Okay.
those risk things that I'm looking for are early onset, so under 50, multiple cancer diagnoses in a family or in that person, and then what type of cancers were they? Were they cancers that are likely to be related to melanoma when it's due to a hereditary cause? Those are kind of the big things I look for.
So telling the difference is actually pretty tricky. And I don't know if I could give you like a real 100% rule to follow, because as I showed in some of my slides, those patients didn't have very obvious looking melanomas at all. But what they had noticed was a lesion on the face that was growing, that was changing, like a brown patch that had gotten bigger or darker. In some cases, it's not even brown. But that's the sort of thing that your dermatologist, if you're seeing a board certified dermatologist who has been trained for many years, 4 years of medical school, 4 years of residency, maybe an additional fellowship on top of that, to try to recognize these lesions. And then if they're unsure, they'll do a biopsy, which is a very simple test of just numbing up the lesion and usually just shaving it off, something like that. So it's a very simple test that can be done to check the lesion. And if you notice something suspicious, then I would have that checked out by a dermatologist if you can. But I don't know if there's a hard and fast rule that I could give everybody. In general, it's like the ABCDs of melanoma: asymmetry, borders, color, diameter, maybe not always, but evolution is a real common thing. These lesions are not just static with time, but they're growing, changing, getting bigger, darkening.
Okay, so question here and then straight back to the dark.
Can you speak a little more about
In
the
there.
low-cost testing you referred to? When my oncologist told me she thought I should have genetic testing because my mother had melanoma, and that if I tested positive, we'd send my kids to be tested. I found that Medicare will not pay for genetic testing for melanoma, only for breast cancer.
So that is very, very true. Medicare typically only covers it for breast, prostate, pancreatic, ovarian. However, so there are self-pay options available. Probably the most famous one is through a company called Invitae out of California, and that is a clinical grade test. So it's a test I use all the time, but they have a patient pay option of $250. So that's completely outside of the realm of insurance. And actually, a little secret, I know that they're actually not billing Medicare for the Medicare patients. So even if your doctor orders it through them, you won't get billed anything actually. Invitae, Invitae. And you can always email me or, give me a call and I can write it down for you. Yep.
Straight back and then back behind you.
Yeah, if I understood my dermatologist correctly, she said something that's talked about something that's coming up, and I'm wondering if anyone can respond to this in the room, which is some screening for melanoma that involves artificial intelligence and machine learning?
Yes, there are apps coming out, like a mole mapper app where you can track your mole and see if it changes over time. There are studies looking at machine learning where pigmented lesions are photographed and then shown to the machine, and then later biopsied, and the biopsy is shown to the machine, and the machine learning can, accurately diagnose melanomas in, I think it was like upwards of 90% of the time, which was around the accuracy of the dermatologists, and the accuracy of other specialties was not as good as the machines or the dermatologists. So those are some of the preliminary studies that have been done, but it does seem like something that is ripe for artificial intelligence to contribute to, because this is not like a pancreatic cancer. This lesion is right on your skin and can be photographed.
You can certainly see in the future where you're going to, just like you go through a detector at TSA, you're just going to go in and you're going to get photographed. And access to that photograph better be very limited. But there's going to be a way for your primary provider with machine learning, with artificial intelligence, to do a very good job at screening. Until that time, see a dermatologist. If you have any question about your skin, I presume everybody in this room is seeing a dermatologist. Dermatologists are really good at doing a scan, almost like the TSA scan. They're really fast, and you go, how can you be that fast? And they know when to stop, and then they focus in on something. So have them look at all of your skin and make sure you're comfortable and they're comfortable, and then having your spouse or partner help with that. The other thing is grid photography is out there now that you may be familiar with, which is not quite the TSA thing, but it is photographing digitally of your skin. It can be in your medical record. That can be pulled out. Because people with a lot of moles, there's no way in the world you're going to know every mole, whether that's changed or not. I think that's a rapidly evolving field. Time for one more question.
For Anna. First of all, where are you located? And secondly, on those pink melanomas, are there any soreness or pain or anything instead of just visually observing it?
I'm at OHSU, Oregon Health and Science University in Portland. And did you ask about the pink melanomas? Is that what you said?
Yeah.
Yeah. No, they don't typically have any symptoms.
Okay, thank you.
I realize we got a little bit late start on this. A couple more questions, maybe. We got one here and one there, and then that'll end our session.
I know this is probably for Anna, but I know you're supposed to cover up as much as possible.
Throw it.
Sure.
But in terms of UV damage, is it too late for most of us? I'm thinking about the future, like how afraid to be of the sun. Is most of the melanomas coming from childhood and sun exposure, you've had for many decades, or should you go hide in a cave? Because
Hide in a cave. No. That's a very good question, a very complicated question. I don't know if anyone can answer that question in the world, but I think definitely there is sun damage that was done when we were young, and the effects of these mutations may be cumulative. So like other exposures that you're exposed to in childhood, by the time you get older, your immune system isn't as good. That's when you may be seeing the effects of some of these mutations, and increased melanoma risk was associated with increased childhood sunburns, and increased number of nevi, and increased number of nevi was associated with increased sun exposure as kids. So there are some associations, but we don't always know that they're causal. And then how important is it to protect yourself from the sun? Well, it's probably important. It may not be the whole story, though. Some of these melanomas occur in the place where the sun doesn't shine. African Americans get a lot more melanomas on their palms and soles, not sun-exposed areas. So there's a lot that we don't know about these melanomas still. And of course, research is being done. I think we're giving our best advice, which would be to, avoid peak sun exposure and use sunscreen if you're going to be out in the sun. But I don't know if anyone can break that down into, a percentage, 20% chance of this happening or 40% chance. It's just so unknown, but there's a lot of research being done.
Yeah, just to add on to that. So I tell patients who ask that question, I say, you've earned your skin. Your skin that you have now, you earned that. You chose to earn it, but this is what you got. That your risk of getting your melanoma was probably 20 years ago. I grew up in Florida. Everybody put baby oil on with a little iodine in it to get, everybody in the country did it. That's probably where the major risk was. What we can do is protect the kids. And children or grandchildren, nephews, nieces, get them involved with skin awareness. We've done it with seatbelts. If you're in a car with a 6-year-old and you don't put your seatbelt on, that 6-year-old, get that. We can do it with kids, and that's where the prevention is for mine. Australia has slip, slap, and slop campaigns because they have the highest incidence in the world. So we can do that. But I would say you earn the skin that you got. Be smart when you're out in the sun, but we're vitamin D deficient in the Northwest. Don't hide from it, but put a sunblock on, put a hat on, keep some coverage. Don't go out in the major times. But we basically earn the skin we have right now. One last question.
So would those melanomas, would they show up on a PET scan typically? And should we all get a black light? And could a regular person just interpret the black light like you saw, where it was stood out, but it wasn't colored, wasn't pigmented?
Well, there are other benign lesions that would enhance with the UV light. So you probably need somebody somewhat trained to sort out what's benign and malignant for you. And as to the PET scan is going to detect like a metastatic melanoma inside the body, but it's not going to be good at like if you PET scanned and there's a mole on your leg, that wouldn't light up even if it was a melanoma probably, unless it was a very deeply invasive melanoma already. So a lot of these early stage melanomas wouldn't light up with a PET scan.
Okay.
Okay, so that was a great session. Well, I really want to thank our speakers from this morning. And we've got lunch right across the hall, but before we do, I think we have almost all of our volunteers in the room here. I just want to put a special thanks out. We have Shelby Monier from Melanoma Research Foundation. You already heard and talked to her. But we've got Carrie Walleen back in the back corner and her team. We've got Ritu, Amy, Carrie, and Terra Nova. And thank you all for really this great organization. So we will see you back in here at 12:15. Enjoy your lunch, network, and feel free to ask us all questions. Thank you.